Is that all right, Noreen?
That's us live, Pam, thanks.
Okay, so are we live now?
Yes, that's us live.
Okay, thanks. Hello everybody, good afternoon, and welcome to the NHS Cheshire Clinical Commissioning Group Primary Care Commissioning Committee. For those of you who don't know me, I'm Pam Smith. I'm an independent governing body member and I'm chair of the committee. I've got quite a few things to say before we start. This is a meeting that's held in public, but it's not a public meeting. And in response to the government's advice on managing the spread of coronavirus, we're holding it as a virtual meeting. So as such, the meeting can't be attended by members of the public. The meeting is, however, being live webcast and a recording will be made available later online. Only colleague officers and members of the committee may ask questions or take part in the debate. And there are too many people on this call, I think, for us all to introduce ourselves. So I would ask that before you speak, you do introduce yourself and you say who you are and what your position is on the committee. But I'd just like to draw people's attention. We've got 6 voting members here today. There's me, there's Wendy Williams, who's a colleague lay member, and Suzanne Horrell, who's also a colleague lay member. And we've got 3 officers, that's Paula Wedd, Neil Evans and Andrew Whittingham, who's deputising for Linda Risk. The committee also has a lot of non-voting members. So we've got GPs, practice manager, local authority representation, NHS England, Health Watch, local medical committee, and we've got a number of officers from the CCG present today as well. And I'd like to extend a welcome to Dr. Paul Bowen. It's his first, hello Paul, that's nice to see you. It's his first meeting of the Primary Care Commissioning Committee and he's going to be a member from here on in. I'd like to just remind people if they would use the chat box to let me know if they wish to speak, but not to comment because that makes it really difficult in terms of minuting and also in terms of me keeping up with what's going on. And can you mute your microphone if you're not speaking to reduce background noise? And can you ensure your camera's on when speaking? It's up to you to turn it off if you want to turn it off when you're not speaking. And it's quite nice to see you all. What I'd also ask is Noreen, I think, is going to remind me by text if I've missed anybody out in the chat box. But if I do miss you, I'm very sorry. Just keep typing in that you want to speak. I'm going to move on to apologies now, and I've had apologies from Simon Powell as an LMC rep. I've had apologies from Fiona McGregor-Smith because she's conflicted because it's a one-item agenda in respect of Sandway, and obviously she belongs to that practice. Linda Risk has apologised because she feels she's conflicted because she's a patient at the practice, and so Andrew Whittingham's in her place and also therefore has a vote. Carla Sutton's apologised. She usually attends, but Kathy Rowlands is here today from NHS England. Welcome, Kathy. I've had apologies from Dan Howcroft, who's our governing body secondary care doctor. And I've had apologies from Laura Judah, who's Centre Deputy Councillor Marilyn Houston from East Cheshire. I don't think I've got any others. Well, I haven't been notified of any others. So in terms of declarations of interest, some of these are noted actually in the papers, and I've already mentioned 2 already. But can I just ask, does anybody else have any other direct or indirect link that should be declared? No? Okay, that's lovely. Thank you very much. In terms of housekeeping, I need to go through the minutes of the meeting on the 27th of August, which have been circulated before, and I know we've just had a couple of late amendments. What I'm going to ask is for, in terms of time, if we can just agree those as a correct record of the meeting. Does anybody have any objection to that? No, lovely, thank you. And we've got an action log. And every single one of the actions, this action log came separate actually to the agenda. There are 5 actions on it. All of them are ongoing. So I'm not proposing to go through them all at this time if everybody's okay with that. Lovely. Moving on then to the actually main item of the agenda. We've got obviously a single item agenda. And it's the consideration of the application from Dambridge Medical Practice to close their branch surgery at Sandyway. And I'm going to go through the format of how I'm proposing to do the meeting, because I've had to think long and hard about this with so many people that are contributing. What I'm going to do first is ask the officers, which is Chris and Matthew, to take us through the covering paper. Then I'm going to ask Dambridge Practice to speak if they want to. And then I'm going to take public feedback. I'm then going to take any feedback from Healthwatch or the LMC that they want to add in. And also Matthew's going to take us through the feedback from Cheshire West and Chester Council's Overview and Scrutiny Committee. And then finally, I'm going to take questions for clarification from committee members. And I'm going to divide those up into each different sections so we've got a bit of clarity about where things are coming from, so we're not jumping around all over the place. So I hope that people are all okay with that. And then I'm proposing we take a break, because I think we'll probably need one by then. And then we'll come back and deliberate and make a decision. Okay. So I'm just going to also remind you there were a number of papers. There was a lot of papers with this agenda item. I'm assuming that all of the committee members have read all of the papers and all of the appendices. Appendix A, B and C have come from the practice. Appendix D is the Equality and Quality Impact Assessment. Appendix E is the Overview and Scrutiny Committee report. Appendix F is the LMC and practice feedback. Appendix G is the feedback from the practice following the Overview and Scrutiny Committee. Appendix H is the Save Our Surgery documentation, and Appendix I is the policy booklet. Okay, so I'm going to move on to the presentations, and I'm going to hand over to Chris and Matthew to take us through the covering paper. Thanks very much.
Hi everybody, so I'll just repeat. My name is Chris Lees. I'm the Associate Director of Primary Care for Cheshire CCG, and for the purpose of this meeting, although I am a member, I'm not a voting member, but I'm here to give you a contractual overview of the process for closing the application to close a branch surgery. Just to give you some background, first of all, Dambridge Medical Practice in Northwich hold a GMS, a General Medical Services contract with the CCG. Those contracts are nationally set and negotiated, but managed locally by the Clinical Commissioning Group. Dambridge Medical Practice have 3 sites of provision for their contract, their main service surgery at Dambridge and 2 branch surgeries at Kingsmead and Sandyway. Under their contract and governed through the National Policy Book, the extract of which was in Appendix I, if a practice wants to remove a site of provision, therefore close one of its branch surgeries, it has to submit an application and undertake a patient engagement exercise, the results of which are submitted with the application. The CCG Commissioner should then consider the application with a view to accepting or refusing it. This committee is the decision-making body for this. There are just some contractual areas I'd like to draw your attention to as a committee. So first of all, the practice have complied with the contractual asks of the CCG, giving the application and the reasons for application within their paperwork. The practice are engaged with and cooperated with the CCG officers throughout the process, including the patient engagement exercise. The practice have confirmed they will not be seeking to change their practice boundary. If the application is approved, therefore, no patients will be deregistered within their existing practice boundary as a totality. The committee should also note that the application is concerned with withdrawing a site of provision, not services. all patients, regardless of where they live in relation to a practice premises and within the practice boundary, are entitled to access to the full range of services provided by a practice as clinically determined in accordance with clinical need by that practice. The committee should also be mindful of the feedback from Thirdale practice contained within Appendix F, who have raised concerns should the application be accepted, and it could impact them adversely. At that point, I'd just like to bring in, if I may, Chair Kathy Rowlands from NHS England, just to confirm that NHS England are happy, as we act under delegated authority from them, with the due process that's been put in front of them.
Yeah, I'm fine with that.
Thanks, Chris. Yes, we can confirm that we are satisfied that the contractual process has been followed correctly. As I spoke with some colleagues in NHS England before I came, and we are fully satisfied. I can confirm that all is in order, and there's enough information for the CCG to make the decision.
Thanks,
you.
Kathy.
Yeah.
Chair, I've got nothing else to add to that section. Sorry.
Okay, Matthew.
Hi, hello. Matthew Cunningham, Director of Governance and Corporate Development for Cheshire CCG. I suppose my element is just to give you a little bit of assurance around the communications and engagement process that was undertaken. Chris has touched upon it in terms of the ask of the practice and the process. As a CCG, we have two elements really for this. One, we have a role to advise the practice on what they should look to do in terms of undertaking a patient involvement exercise, and I won't articulate everything in the paper because there's quite a large amount of information articulating the level of detail that the practice undertook. The second element is that as a CCG, we also have a duty to consult with the local overview and scrutiny committee as part of this process, which we duly undertook as part of this process. And again, I'll touch upon a little bit that later on around OSP, but again, as part of the ongoing process for the committee, part of the engagement process is to take on board the myriad of different information that comes to the CCG around this particular topic. So it isn't just necessarily the information that was collected and submitted by the practice in terms of engagement. We are still in that kind of process around engagement today, listening from members of the public as well as other partners around this topic as well. So in that respect, we are still meeting our duty to engage, but also we did meet our duty to consult with the Health and Social Care OSC of Cheshire West Council. I suspect probably the benefit will be for me to answer questions later on around certain elements of the engagement process if you wish, but just to reiterate Chris's earlier point, we believe that the practice undertook the ask of the CCG in terms of engaging with its patients as part of the application process. And I'll leave it at that, Pam.
Okay, thank you very much, both. You don't want to say anything more, Chris, no? Right, that's lovely. I'm going to move on then to ask Dr. Mike Mullen and Mandy Skending-Jones if they want to say anything further to their application.
Thank you, Pam. I think a few things I would like to say, if I may. Obviously, this is a big decision for the practice, so I was just going to run through a few of the points which were in our application, and then a few other bits and pieces just to perhaps put things in context, if that's okay. In terms of this making this decision, I think there's been mention of the CQC visit. I think we made reference to that in our application to close the surgery. Really, that visit was a catalyst for us looking at the closure of Sandyway surgery. There was nothing specific in the report from CQC, but I think as a group, as a partnership, we recognised more so then than ever that we are held by standards both by the CQC and of course the GMC. And it made us look quite closely at the service we were able to offer from Sandyway surgery. And that really led us to think that we can't offer the service which we would wish to from that practice. Certainly nothing in comparison to what we can do from our other two sites. In terms of what we're doing at Dainbridge, this for us, I think, feels quite awkward and uncomfortable, because in many ways it is being viewed as a negative thing. And of course, I can understand that from many of the patients. We do get that, of course. And that's awkward, I think, for us as a group of doctors, because we're very much trying to construct something, trying to build something here at Dainbridge. And this, unfortunately, can easily be seen as exactly the opposite. But at Dainbridge, we do invest in our staff, we invest in the building here at Dainbridge, and we've put a lot of money into this practice in terms of trying to make the building fit for purpose here at Dainbridge. And you know, our approach to this is trying to create something which is good for our patients, and we believe that we can do that much better across 2 sites rather than the 3 sites we currently have. In terms of the specific reasons for closure, obviously this has all been set out in great detail in the application to close the practice. But just to quickly run through some of the main points, it falls into 2 areas really. One is the building itself, and also the other issues of staff working in that building. So to take the first, the building itself, some of you I know have seen, is quite an old building. We don't believe it's fit for purpose for offer a modern primary care service, which we can from our other 2 sites. Particularly specifics are the rooms are very small. One room has a couch attached to the wall. It's a small couch. It's difficult to get off and on certainly for elderly patients. It compromises the clinicians to an extent in terms of examination, putting them at risk, and also I think putting patients at risk. But the room itself, it's difficult with just 2 people in there. It's relatively small, but when you add relatives, wheelchairs, prams, etc., it does make things very difficult. In terms of the building itself, confidentiality is an issue. The walls are very thin. Sitting in the waiting room, I know some of the panel here today have been to the practice. Sitting in the waiting room, it is very audible what's happening inside the room. So of course we have radio, big TV blurring out to a certain extent to try and mask that, but it's far from ideal. Certain issues of health and safety as well. We don't have a modern fire alarm system in there. That does cause us some concerns. And also hygiene was mentioned by during the CQC visit in terms of flooring, and it's carpeted. And although we clean it regularly, it is just a matter of getting it clean. Obviously, at our other sites, as many practices now, we have much more appropriate flooring and wall coverings, things which are more clinically suitable. The other big issue for us is the staff working at the practice. We have our partnership, but of course we have a number of salaried doctors who we employ. Salaried doctors, our salaried doctors certainly are more junior the more junior members of the team, and don't like working on their own, and often at Sandyway that is what's expected of us. And typically it would be a doctor on his or her own with a nurse, or sometimes without a nurse. That certainly presents us problems which we've highlighted. Doctors often would like a second opinion, and junior doctors certainly very much enjoy that team approach and often will ask for help. And it's not easy to do that when you're working on your own in a practice. We do have other technologies now, of course, pick up the phone, video techniques, etc. But nothing is quite like having another pair of hands have a look, another set of eyes, look at a patient, look at an ECG, etc. And that's one of the issues we have. Also, that's true for the nurses. The nurses very much are used to working as a team, and I think do certainly feel vulnerable and exposed, as do the doctors when they're working at Sandyway, certainly the more junior doctors. That in itself has problems for us because, you know, we're aware that there is a recruitment crisis in general practice, and getting salaried doctors into the practice and working for us can be difficult if they're working in environments which they're unfamiliar with or not happy with. And so that's certainly a concern for us. Also, the practicalities of running a surgery, you know, as we used to do before the COVID pandemic hit us, in terms of something unforeseen events happening. We all get this in surgery, sick patients. It's very difficult to deal with that in a busy surgery at Sandyway. As we know, we would often want to put a sick patient who's waiting for an ambulance in another clinical room where they can be observed. There aren't the facilities for that at Sandyway, and that does put a lot of pressure on the clinicians. As we know, sometimes in primary care you can be waiting for an ambulance for hours to arrive, because they don't see us as a priority, understandably, but that does present problems. And these unforeseen things happening within a surgery at Sandyway are not as easily dealt with there as they are at our other site where we're a team, and there's the flexibility of the team. All these things put the clinicians under additional pressure, which we feel then can lead to adverse outcomes for our patients. So that really is the nub of why we want to close the surgery. I just wanted to say a few words, if I may, just about the effects of the pandemic and how we have embraced that with the technologies involved, and how that, I feel, should have an impact on the decision made today. As with all GPs, certainly, you know, we're doing things very differently now. And just to put things in context for the panel, you know, we've been looking at some statistics. We work very differently now. We're doing total triage, as I think most practices are now. And we've worked out, we're seeing approximately 20% of our patients face to face. The rest is being dealt with remotely, whether that be telephone, video consultation, e-consultations, text messages where photographs are being shared with us. So all this new technology, which Dainbridge, as with many other GPs, I'm sure we've embraced, I think does influence the decision, because we're offering a different service than we were. And we can do that essentially from Dainbridge and Kingsmead as easily as we can as clinicians from Sandyway. And we feel that that is not going to impact greatly. The closure of Sandyway would have less impact in this new environment within which we work. And I think, I suspect, as with many other clinicians, that this is the way we will be working in the future as well. A few things I'd like to say, if I may, just about the thoughts we've had as a practice about trying to mitigate the closure of the practice. A number of things have been raised by the Resident Action Group, which I think are very valid questions. One was around prescriptions. Certainly at the practice, we very much push electronic prescribing and prescriptions, and a very large proportion of our prescriptions are done electronically. That certainly, if Sandyway were to close, I think would be a service which those residents would very much benefit from, and we would certainly embrace that and encourage that. We also have a high proportion of our patients on repeat dispensing, which should also reduce the need for patients to be coming into pharmacies, coming into the practice with paper prescriptions. We're very much trying to get away from paper prescriptions, although we do recognise the electronic approach and electronic services are more difficult for certain members of our patient population, certainly the very elderly and the more vulnerable patients. In my experience, and I'm sure other GPs as well, you know, patients well into the 70s, early 80s are embracing the technologies we're using with text messaging and video calls, but I appreciate it is more difficult for certain members of the society, and certainly certain members of certain patients of ours who are more vulnerable than older patients. We understand that. We are trying to promote a dialogue between our pharmacist and our in-house pharmacist and the local pharmacy, Rowlands, and trying to see how we can work together. One issue which has been raised is the meds monitoring. We still have been using the booklet system for our DMARDs, our immunosuppressants, which means, perhaps for those who don't understand, means that a patient in our practice hasn't been able to use the electronic prescribing system if they're on that type of medication. A number of Sandyway residents will be. In fact, we've looked at that, and in line with many other practices, we're going to move away from that system so that these drugs can also be requested electronically, which I'm sure would help. There's been mention of samples, dropping off samples. We haven't got a solution to that, I'm afraid. Samples would need to be dropped off at both Dainbridge or Kingsmead site, and we can't really see another way around that. And finally, transport issues have been mentioned, and we would certainly be very much in favour of the Cheshire Car scheme to be used as much as possible, or any other schemes which will be available locally, which we understand are cheaper than a taxi, still not without some cost. In terms of the reports to the CCG from the Resident Actions Group, if I may, I just would like to just quickly go through a couple of the points which were raised there, again, just to give our response to them, just to try and add clarity more than anything. In terms of our reasons for closure, there were questions around that, and I think there's been mentioned already during the meeting that there'll be no less capacity as a result of the closure of Sandyway surgery. We have no intention to be requesting the change of boundaries, and certainly won't be delisting any patients, and won't be asking to close the surgery list. All the work which we will continue to do will continue to be from our other two sites. Things which need to be done face to face will be at those two sites, which are much more modern buildings, and certainly Kingsmead is a much more modern building, and we've done a lot of work here at Dainbridge to make this much more modern and clean and hygienic, and a much more clinically appropriate environment, such as immunisations, blood taking, ECGs, etc. And as I say, currently around 20% of our contacts are face to face. There has been mentioned quite rightly about focus groups. The practice did promise to or agree to organise focus groups following our public meeting. We haven't done that, and we're unable to do really because of the onset of the pandemic, and obviously our focus changed somewhat, so we haven't done that. In terms of the process itself, you know, we have been supported by the CCG and guided through the process, which of course has been unfamiliar to us, but we do believe that we have done what's been asked of us. And just finally, a few more points in terms of, as I say, I think the geography of Sandyway itself and its physicality is less important now than it has been in the past, in terms of the way we are now working, the new normal, as we call it. We have approached other surgeries in terms of who would anybody have been interested in taking over the practice. We did have one response, I understand, expressing interest, but again, since the pandemic has unfolded, I think needless to say, there's obviously less interest now. And of course, any other practice taking over that surgery would I'm sure, be faced with the same problems we have been faced with. There's been mentioned that the local pharmacy would be at risk. We understand the concerns there. Again, with electronic prescribing, I don't foresee patients going to another pharmacy, so I'm not sure if the pharmacy there would be at risk. Parking, again, our footfall is much less here at the practice, so at Dainbridge and at Kingsmead, parking it would be certainly improved. Here at Dainbridge, parking is no longer an issue with, as I say, only a fifth of our patients actually coming into the surgery for face-to-face contact. Home visits, we have looked at that. Interestingly, since we closed Sandyway, which has been closed for a number of months, recently opening really because of social distancing problems with staff and having difficulty staffing it, we didn't notice any increased home visits from that area. It isn't true to say that we only visit housebound patients. In the main we do, but of course patients who are too sick to come to the surgery and are unable to travel because they're too sick, certainly we would offer a visit and always have done, would continue to do that. We do have a system for home visiting which has worked well, and I wouldn't see that being a problem if the surgery in Sandyway were closed. We have assistance from a rapid response team, two very experienced nurses who do lots of visits for us, and indeed we have looking, as many other practices look at them, potentially employing paramedics at some stage, and one of their roles could be home visiting. So we don't think that would be particularly an issue for us. as Chris Lees mentioned earlier, there'd been no intention to attempt to close the list or change or ask if our boundaries could be changed. And that's pretty much it really. I'd just like to say make one more point, if I may, which is around capital and investing capital into any renovations or project work around the building of Sandyway. With a lot of thought, I think it's true to say that that would create problems, we think, for our partnership if we had to invest a significant amount of money to renovate the surgery. We have a partnership model at Dainbridge which has worked very well for decades, and I think there could be significant problems if further significant investment was required. The quotes we've had is around about £300,000 plus mark. With investment from NHS England, I think would be having to find about a third of that up front and potentially the rest within time. The great difficulty that would create for us, I think, would be recruitment. We would very much like to continue with the partnership model here, which works for most practices, I think, certainly works very well for us. I think it would be at risk if any new partners coming into that group had to invest a lot of money. It's difficult to get salaried doctors and recruit salaried doctors, but partners is another ask again. A partnership model works very well because the partners do so much within a practice, leadership, mentorship, direction, and it is great for patients really because it ensures that the service is running smoothly and that everybody's working together as a team. And I think that could be certainly undermined if a lot of capital investment was needed. Some partners are about to retire, I'm sure, over the next 2-3 years or so. I've reluctantly found myself to be a more senior partner these days, which is kind of crept up upon me, so eventually I'll be gone at some stage. But we very much want to replace partners, and that will be difficult if new partners would have a substantial financial outlay. So that's it really from me. I hope I've not gone on too long. And that's it.
No, that's
really.
fine.
So thank you.
Thank you. Man, did you want to say anything? Are you okay with that? No, Mandy's not. Right. I'm going to move on then to the public feedback section of the afternoon. And before I ask the Save Our Surgery group to speak, I'm going to read out a statement that I've made in respect of a telephone conversation which I had with the Dainbridge Patient Participation Group, because it's a requirement under the contract for the practice to have a patient participation group. And I spoke over the telephone with a member of that group. Basically, they were saying that the patient participation group, which I'm now going to call the PPG for short, were informed last November about the proposals to close Sandyway. They were updated regularly by the practice manager, and they influenced the survey and letter that was sent out. And 4 members of the PPG attended the consultation events to help the organisation of those. 3 of the patient participation group members live in Sandyway, but the others on the group don't. The members of the group were wanting to understand the reasons for the closure, and this is still evident from the notes of their meeting on the 27th of October, when further clarification was sought regarding the building issues, the CQC report, and what was said at the Overview and Scrutiny Committee. The group were aware of the results of the consultation, which was 79% of Sandyway residents were against the proposal, which was 53% overall. There is, however, no consensus in the group about whether they agree to the closure or not. At its meeting in October, the group had discussed the proposal, the consultation, patient and staff safety, the building and the effects of a closure on patients. They also asked if other options have been explored. I'm satisfied, therefore, that the patient participation group were involved in a timely manner with regard to the proposals, but the PPG representative declined my invitation to attend the committee because he had a prior commitment, not because he didn't want to attend. So I just thought I needed to let people know that I'd made that contact. So I'm going to move over to John Kerrigan now from the Save Our Surgery group. I think John's going to be brave and do a PowerPoint presentation. Is that right, John?
I hope the technology is going to work. I assume somebody at your end is working it. Yeah.
So do I. So Noreen, have we got the presentation that John wants to do? Oh, there we go. Can everybody see that? Yeah,
Okay,
lovely. Okay, over to you,
much.
John.
Okay, thank you. Well, first of all, I'd like to thank the committee for receiving our report and actually giving us the opportunity to say a few words today. I think that's really highly valued by the patients and all the residents here that are involved. Okay, go to the next slide, please. First of all, just a few points about the importance of Sandy Way surgery. And of course, we are talking as patients. We're not experts. We're not experts in the NHS or in medical practice. So we look at it purely from our perspective. There's been a surgery here since 1928, it's a long time. But it serves 3 rural settlements, and it's the only primary care facility here. And it does, for all that it's over recent years, the service level has been reduced in terms of nurse attendance or appointments available at Sandy Way. It does carry a significant patient load. So even at that level, a change which meant that Sandy Way was no longer available to the practice will actually increase the load significantly on the other 2 surgeries. So there are 3,747 plus or minus, because we know that the practice numbers keep moving around. That's the way things are. But there's 3,500 patients here, and it's a significant percentage of the village residents, in fact, that are patients. And 38% of those are under 16 or over 70. So either they can't drive or they're unable to drive. And we'll talk more about transport and access a little later on, but that's an important statistic in itself. And as you can see from the stats that Damebridge have given us, there were 6,000 patients seen there in that 12-month period, April 19 to March 20. And again, I know things have changed with COVID-19, and again we'll refer to that later on, as Dr. Mullins already mentioned some of those points. When the survey was carried out, 79% of the respondents in this area voted against closure, so they would prefer that Sandy Way stayed open. And in fact, the survey, as you know, was carried out right across the whole practice. All patients were contacted. And a majority, close on 55% of respondents to the whole survey, right across the practice, were saying they didn't really want the surgery to close. So it was all very much in favour of keeping the surgery open. There's something I know that the practice say they were not aware of, was the whole issue of the key service centre. This is a concept that Cheshire West have got for significant communities that provide services to a wider community. So Cuddington and Sandy Way is considered a key service centre, which means it provides social and welfare provision for a much wider area. It's not just the village of Sandy Way or Cuddington. And this key service centre was nominated because of the level of social facilities, shops, village hall, that kind of thing, sporting facilities, but significantly welfare, like the doctor's surgery, dentist, that kind of thing. They were all factors in that determination. And based on that, the key service centre is developing, it's growing. There are already 300 new houses have been built here as a result of the fact it is seen as a key service centre. And we really need to retain a key primary care facility in that key service centre. Now, we're not asking for something new. We're not asking for somebody to come and build a surgery. We want somebody to look at that surgery building, give it some TLC, which is long overdue, and just modernise an existing asset. So it's not about building a surgery from scratch. It's about putting right what's already there. Next slide, please. So how will this affect patients? Again, from the patient perspective, well, it's closing the medical services, leaving us with the nearest medical services in Northwich, Kingsmead, obviously, Winsford or Weaverham. Now, there are no viable public transport links to get to appointments at these surgeries. There, in the various papers that you'll have seen for this meeting, there are times given for bus trip journey times, that kind of thing. The fact that Weaverham is only 2 miles away is sort of irrelevant, because it's actually 2 bus journeys to get there. You can't go on a bus from here to Weaverham. You have to take 2 buses to get there. So you have to go into Northwich and back out again. The buses start at 8 o'clock in the morning. That's the first bus, but then the second bus isn't until 10 to 10. So, and then they're hourly thereafter. So an hourly bus service, but it only really starts at 10 o'clock. So the idea that you can take an appointment at Danebridge or at Kingsmead and readily get there using public transport, we believe is a little bit misleading from the data we've got. It is acknowledged actually in the QEIA that the Sandy Way proportion of the practice would be negatively impacted, particularly with regard to travel and distance and access to appointments. So we were asking, well, why change then? There's an asset, there's a building, there's a surgery, it needs TLC, so why are we changing? What would the outcome from this is that 3,500 patients are going to be left 5 miles from their nearest Danebridge surgery with no reasonable access other than by car or expensive taxi. The voluntary car schemes that are referred to, they're not realistic means of transport to an appointment, given that you have to book in advance and you can't at short notice summon up the voluntary car scheme or dial a ride. And not everybody's eligible for dial a ride. Only certain people are eligible for that. So closing the surgery really denies a significant proportion, we believe, of vulnerable population to primary medical care. There's a lot in the press, and Dr. Mullen has made quite a lot of input there on e-consultation, and we recognise this is the way a lot of GP practices are going to be going. But they're only a partial solution for patients' problems. There are a number of things can go wrong with remote consultations, and I'm sure you're well aware of that as practitioners. They're not risk-free, and I'm not sure, but I guess you would know, have risk analyses been done on whether or not e-consultation is a safe way to consult? Is it how much more effective is it than face-to-face? There must be things you can't do on the telephone. You can't take a blood pressure, you can't take somebody's temperature. The sort of things that routinely, when you go and see a doctor, they get done. And lots of things can be picked up by a doctor-patient interaction in a room. There's no doubt about that. There's again, in the papers, it talks about the fact that there's been no complaints about the new way of working, the e-consultation that's been brought about by the pandemic. I think it's not a particularly strong argument to say that we've not been complaining about the NHS during the pandemic. I think most people have been applauding the NHS, and it would be a pretty mean-spirited person who would complain today about poor access to a GP surgery or whatever in the pandemic that we're currently experiencing. So I don't think assuming that what's happening now with e-consultations is totally satisfactory for patients is a fair assumption to be making. A lot of people, older people, don't have access to the equipment and to use these kind of services. They don't have the confidence to use the telephone. So I think it's difficult for older people to engage with these new ways of working. And I think it's early days to be assuming that can actually work in the long term for a community such as ours, where we're going to be, as I say, 5 miles from the nearest surgery with poor public transport. We're really saying that the retention of the existing surgery is essential for patients with problems, physical or mental, that've got difficulty with telephone or video consultation. You could add to that young families, parents with who have got young babies. One of the things that as a young parent you want to be able to see a GP when your child is sick. Doing it over the phone or video links, not the same experience as actually letting a doctor see your baby and look after it. The practice survey shows that according to the QEIA, there's not a lot of people using the surgery. Well, there aren't great numbers because there aren't that many appointments being offered at Sandy Way. I think it's a matter of how the process is being managed rather than patient choice. And in fact, when you look at the survey, the questionnaire, what patients were not asked where they would prefer to go for an appointment, they were asked, where do you go for an appointment? Where you go is where the practice directs you. So if the practice directs you away from Sandy Way, that's where you will go for your appointment, if you can get to it. Next slide, please. We've heard quite a bit about the reasons for closure. We've read a lot in the papers that we've had for this meeting. What I'd like to do is just to refresh people's memory on what patients were actually told, and that's the important thing here. Is patients were given information back in December about why it was important for Sandy Way to be closed, why the practice was choosing to close Sandy Way. And we're given really 3 or 4 points. And although we kind of skipped over that in the DMP presentation earlier, the first point was, and very clearly implied, that the CQ audit had, which gave the practice a requires improvement rating, related to safety issues at Sandy Way. I think if you read the letter that was sent to patients, you read the first frequently asked question on the sheet, it all talks about the Sandy Way and the issues at Sandy Way. The CQC actually downgraded the practice, citing management and leadership failings across the whole practice. There were examples of how that was exhibited at Sandy Way, but actually it was to do with management across the practice. And in fact, CQC said that Sandy Way is fit for the services it's being delivered there. They said that safety issues at Sandy Way required significant investment, which are not affordable. At that time, they're not costing any work to upgrade Sandy Way surgery. And grants are obviously available for that kind of work, I guess. No doubt there is a queue and a rationing system, but that work had never been done prior to the patient consultation. The only data that was available at that time was that the NHS had quoted saying that to demolish Sandy Way and replace it with a brand new surgery was 1.16 million. That's not what the patients feel is needed, and we know that that's really not what the issues are now about Sandy Way. That's become clear. But at the time of the consultation, that was the information in front of the patients. They're saying that Sandy Way could not be sustained because of a shortage of salaried GPs. We don't understand how closing Sandy Way will improve the patient to GP ratio, but we're not professionals, so we don't understand the detail of these things. We can't see how it will change that ratio. It was Cambridge was saying that provision of modern primary healthcare was becoming increasingly difficult to deliver across multiple sites. They're still intending to run 2 surgeries within 1 mile of each other and close the surgery that's 5 miles away. So if they need 2 surgeries, why not spread it a bit more evenly than that? What the reasons for closure now given by Cambridge to the PCC are different from those that were put in front of the patients in December and January. We think that's important in two ways. One is important in terms of the transparency of the consultation and the credibility of that process, since the ground has shifted completely from that particular set of points that were made to the patients at the time. The issues of lone working, well, we would like to talk about that, because there are 16 practitioners' names on the board outside Dambridge Surgery. So there are 16 practitioners there. We can't understand why we can't get one experienced and less experienced person at Sandyway for the period of half a day, every day, which is what was being offered prior to the COVID outbreak. Why does it have to be a junior doctor working alone or without a nurse? For many years there were nurses at Sandyway, but that's gradually been withdrawn as a service. Again, management decisions to do it that way. The point made about the difficulty in carrying out safe and meaningful examinations of patients, talking about the size of the rooms and the fact that some of the inspection beds and so on are fastened to the wall. We would like to, we're kind of wondering, because from our own experience, not every room in Kingsmead, not every room in Dambridge has got these facilities that we've been told are not there at Sandyway. So Sandyway is no worse than any other surgery in the patient's view. No doubt the doctors have their own personal views, but we would question whether the physical facilities at Dambridge and at Kingsmead have had the same level of scrutiny as the Sandyway building has. Because certainly patient experiences that you can go to Dambridge and you go in a very small room and there won't be a 360-degree bed and it won't be automatically movable. The submission that you've got before for you is from Dambridge is actually very different from the original submissions that were given and consulted on with the patients. And the OSC has commented at length about the quality of the consultation. So I won't repeat all the comments that are in their report, but some key points that they feel that they, as a committee, did not really have a full and comprehensive picture of the likely impact on patients and the local community due to nobody being there to answer questions from Dambridge, and also from the fact because the equality impact assessment had not been carried out at that point by the CCG. They were not reassured either of the implications of the closure on vulnerable patients, and I think that the patients themselves are feeling the need for that kind of reassurance, because what we don't know is what happens after the surgery closes. All we know is that we have to travel into town. Whether we can get there or not, that's our problem, and we understand that, but that doesn't seem to be an answer to the issue that's being created by closing an existing surgery. It's already there. We're not asking for something new, as I said before. It's just maintain what we've got. Next slide, please.
John, can I ask you to whiz us through this? I'm just conscious of the time.
Yeah, sure. Yeah. So we're asking the PCC today to refuse the application by Dambridge to close Sandyway. We're saying, we believe, and we would say that access to alternative medical centres is nearly impossible by public transport. It's difficult by car, especially for vulnerable people. Patients, elderly in particular, need a real person to provide advice on what help is available. And closure, we believe, is in direct contravention of NHS core values to provide services that meet the needs of everyone. Closing this surgery will not meet the needs of everyone in this area. It's also, we think, counter to the CCG overview plan and then undermines the assumptions of a quite local plan. It will close the medical provision in the villages to a level below what was available before the NHS came into existence. And it it denies access to primary medical services to a significant number in the villages and surrounding rural area. Now, we're not asking for a new surgery, just the retention of the existing facility suitably upgraded. We don't think that the answer is for vulnerable patients to find their way into Northwich to get to an appointment. We don't think that is the answer. And if the practice don't wish to manage, we think that the CCG and PCC need to consider how they can discharge their duty of primary care provision to 3,700 patients. We've said all along we're willing to actively engage with the practice. Yes, things got thrown out a little bit by the COVID pandemic. The consultation process was brought to an abrupt halt. So we wanted at that point for the consultation, if the consultation process couldn't continue, that we shouldn't continue with the idea of closing the surgery. But DMP, Daimbridge, were keen to continue with their plans to close the surgery. So we've not been able to complete a proper consultation. But we would like to work with the practice or the CCG and look at how we can continue to have primary care in Sandyway. Thank you very much.
Thank you very much, John. That's lovely. In terms of listening what the public have to say, I've also got two other things that I need to read out. We've had something posted on our website. I don't know who it's from, but it says, I'm extremely concerned how the less able will be able to access initial medical care if Sandyway surgery closes. As my mother's carer, I was able to push her to the surgery. However, without this local amenity, a return taxi ride will be needed. For a taxi with wheelchair spaces, it is both extremely expensive and hard to find. This also applies to anyone using substantial walking aids or buggies. With toileting issues, a more public service which would take longer is out of the question for many elderly people. Sandyway Service provided an excellent caring service. It is totally unacceptable that more people should be competing to use Daimbridge, not a welcoming place at the best of times. And I've also had an email from Edward Timpson, the MP. I'm writing to you on behalf of the Sandyway Surgery Residents Action Group and Cuddington Parish Council, who represent the patients of Sandyway Surgery. I am sure that you are aware that the presence of a GP surgery was a very significant factor in the decision by Cheshire West and Chester to designate Cuddington and Sandyway as a key service centre when making the local plan. In December last year, Daimbridge Medical Practice wrote to patients to say that it was their intention to close Sandyway surgery. I've been regularly involved in correspondence with the Action Group and constituents since the start of the campaign to save the surgery, and I am fully behind the group's ambition to sustain a medical centre in the village. The Residents Action Group has produced a report for your committee, which I understand you will be circulating to your members. I recommend this report to you, and I would like to thank you for giving them the opportunity to speak at your meeting to put their case to your committee for the retention of Sandyway surgery. I believe that there's a strong case for maintaining a surgery in this key service centre, servicing some 3,747 patients, approximately 65% of the residents. My understanding from discussions at the Cheshire West and Chester Health Overview Scrutiny Committee meeting on the 12th of October is that there are possibilities to seek funding to upgrade the surgery at significantly lower cost than those communicated by Daimbridge Medical Practice to their patients. I'm committed to supporting the campaign and would encourage the CCG and Daimbridge Medical Practice to seriously investigate options other than closure. If I can assist in any way, please do not hesitate to get in touch. So that was from Edward Timpson, the MP. I think that closes our public feedback session. And I'd just like to move on to ask William from the LMC if he's got anything he wants to add. William.
Thank you, Chair. Just very briefly to introduce myself, my name is William Greenwood. I'm the Chief Executive of Cheshire Local Medical Committee. For those not familiar with the Local Medical Committee, we represent the views of the GP profession across Cheshire. With a different hat on, I am a member of my local PPG, and I live in a village of 1,600 people, 6 miles from our practice, and the bus only runs 3 times a week. So some of the things we're talking about are not unusual. We were approached early on by the CCG for our views on the proposal to close the surgery, and we were also approached by the practice and had some discussion with the practice for the reasons behind it. We took the details that we had at the time to the full committee for consideration, and the committee supported the closure of the practice, largely around the current impact on the workforce of the practice and how it could continue to meet a high quality service moving forward. And in that respect, I'd echo some of the comments that Dr. Mullins made around the ability of practices to attract new partners and new sessional GPs. I'd also want, Chair, if I may, just to commend the action group on their work, because I think they've been quite thorough. But there are a number of issues that haven't been discussed, although they were touched on. I think John mentioned 300 new houses, and knowing Cheshire as I do, I think that number is likely to increase. So that would put even more pressure on the current practice premises as they stand. I can't comment on the other alternative options for premises because I'm not aware of what they are. But certainly sometimes in making premises acceptable for current standards of practice, it's actually cheaper to demolish and start again, I have to say that. But overall, as an LMC, we supported it for the reasons we thought the factors behind the planned closure were reasonable. And in planning for the future, we felt that the closure of the surgery may in fact allow for other developments to take place, bizarrely, but they might well do. But using the current premises, I think there would be a substantial cost to the CCG as well as the practice in developing them to a reasonable standard. I won't say much more than that, other than to say that we appreciated the openness of the practice in talking to us about the decision. Thank you.
Thank you, William. Louise Barry, I'd like to hand over to you from Health Watch. Have you got anything you want to add, Louise, or anything you want to say?
Thanks, Pam. Yes, please, just briefly. So I'm Louise Barry. I'm Chief Exec of Health Watch Cheshire. And for those that perhaps don't know who Health Watch Cheshire is who are listening in today, we are there to represent the views of the public around health and social care. So we were first made aware of this via the CCG. I think the reports indicate that was December. Our first email was actually in January. We then were invited by the practice and the Save Our Surgery group to various meetings. So staff members of mine attended at the time, and a report of all the information that we received has been given back to various parties so the comments can be seen. I would just like to thank Mr. Kerrigan, and I know there's a lot of people behind him in putting the work together that's been done, but I think it does need to be noted that he has come up with some incredibly compelling points. I know that team members of mine were concerned at the time that and it's on record of me discussing this at the Health Overview and Scrutiny Committee, that the consultation did seem to be fragmented. It did seem to be, and there's reasons for that. There's reasons for that of timing, of politics. There's all sorts of reasons for that, but nonetheless, it did seem to be less than smooth. I also think there was some confusion over the rationale of the CQC argument, if you like, when that was sort of unpacked, and that didn't appear to be the case. I think there's been some really interesting points about what is and isn't available in the other surgeries. I've watched the video. I couldn't speak for the other two surgeries that are there. I think, well, if we look at the gunning principles, I think we do as a committee need to consider that was the spirit of those followed, as well as the detail, so as well as the kind of tick box element of that. It should be acknowledged that obviously with the support of the CCG, there has been a process gone through. But I would just like to urge people to take on board some of Mr. Kerrigan's points and to consider the really important role that the Key Service Centre has and the missed opportunities that there were in approaching this from a sort of care community perspective. So I think that's all I'd like to input, Chair. I'll pass back over.
Thank you very much, Louise. I'm going to move on then to Matthew to talk us through the feedback from Cheshire West and Chester Overview and Scrutiny Committee. Matthew.
Thank you, Pam. just to reiterate again, Matthew Cunningham, Director of Governance and Corporate Development for the CCG. So I mentioned it before, one of our duties as a CCG is to engage and consult with the local relevant scrutiny committee when there is a significant service change, and the potential closure of a branch surgery triggers that need to speak to the scrutiny. Now, once we became aware of the proposed intent of Dainbridge, we did start that kind of conversation with Cheshire West and Chester Scrutiny as to when could we come to speak to you about it. Now, obviously, the pandemic happened, and you know, a lot of changes happened there. But I just really like to thank the chair of the scrutiny, as well as the officers of Cheshire West and Chester Council, in being able to put on a scrutiny meeting at our request, really, in early October, as well as really the fully engaged approach that they've had around this process. So we did go to the scrutiny on the 12th of October, which you've got some details about that in the cover paper. And you know, again, John was there for yours, and it was a really good and open conversation, some good challenge, really well managed. And not long after that, on the 22nd of October, we received a report from scrutiny, which you know, attendees have got access to. As a CCG, we have a duty to respond to that, and we've committed to do that following what comes out of the primary care committee today, and we are scheduled to go to their next OSC committee on the 18th of November, where we'll provide an update as well. So in terms of the report, it was a good comprehensive report. I'm just going to cover a summary of some of the feedback rather than read it out verbatim, because I know you've had that. But I think for those who've read it, you've probably heard very similar themes to what you've heard both from Louise and John in terms of the process and the rationale. So in some of the summary highlights, you know, the scrutiny committee didn't necessarily believe that the period of the consultation was adequate, considering what the discussion was around. And equally, the detail in the consultation didn't really adequately cover alternative proposals to arrangements around primary care if the practice was to close. Very similar to what we've heard just there. There was a little bit concern around the emphasis on digital working. You know, if the practice was to close, and how that would impact on poorer, more vulnerable or older patients. And I think we've talked a little bit about that already today. They absolutely accepted that the recruitment of GPs was a challenge, and they recognised that, but definitely thought there could have been a more, maybe an imaginative approach to try and attract GPs to come to work at Dainbridge, as well as integrated working with other professionals. They definitely raised some points around not enough information about what improvements could be done at Sandy Way, and I think we talked about point in time as well. There was definitely concerns raised around the practice not necessarily factoring the impact of this closure on really the future longer term developments within the area and Northwich as a whole. There was further feedback, which I think have really echoed a lot of what you've heard today from John and others. There were a number of recommendations that came out of that report, and if you forgive me whilst I just bring them up, but you will see them in the main cover paper. But I think that the main thing to sort of highlight in terms of their recommendations really to the committee, and again, going back to my earlier point, we are still in this conscious consideration sort of phase as a CCG around this sort of decision. So what they gave us 4 recommendations in this report. One, that the primary care committee looked to postpone the decision around the closure. And again, that was on the basis that the consultation did not fully accord with the governing principles. That the engagement and consultation process should be revisited in light of that first point. The strong patient voice, which we've clearly heard today and I'm continuing to hear, and as well as the obviously unprecedented demands and circumstances that COVID-19 has brought us. The committee didn't feel, as I said there, that it had a really full and comprehensive picture really of the likely impact on patients in the local community. Again, at that sort of committee at that time, they didn't have access to the equality impact assessment, so they were probably missing certain elements of the information, so I can understand that sort of point. And equally, their other recommendation that they didn't feel they were really reassured that the implications of the closure for vulnerable patients had been adequately identified and addressed by the practice before the submission of the application. Again, just to reiterate, the role of scrutiny was really, again, to look at the process that was undertaken around engaging and consulting with the public and the patients in particular, sorry, of Dainbridge. Their role wasn't necessarily to, make a decision as to whether it should or should not close, but absolutely, and I'll reiterate this to you as members of the committee, the feedback from the scrutiny committee is really a vital part of the overall feedback that you should consider as part of considering the application as well. I will leave it at that, Pam, because I'm conscious of time.
Okay, thank you very much, Matthew. That's very useful. I'm going to move now to question and answer session from members of the committee. Just a reminder that I just want you to ask questions of clarification. I don't really want to get into the debate bit yet. And I'm proposing that we do this in 4 different bits. So has anybody got any questions that they have for Matthew or Chris in terms of the covering paper, the policy book, EQIA, or the overview and scrutiny report? Has anybody got questions? There's nothing coming in my chat box. No questions? Right, okay, I'm surprised there's no questions at the moment. What about questions of the practice? Has anybody got any questions they want to ask the practice? Suzanne.
Yeah, I'm off mute. Okay, thanks. Yeah, I just wanted to ask the practice, do they have any vacancies at the moment for GPs and nurses in terms of their recruitment?
Who'd like to answer that? Mike?
Yeah, shall I take that?
Thanks,
I'll take that one. Thanks, Suzanne. Yeah, currently we do. We in the practice, there are always vacancies. It's a fluid state. With the clinicians and the doctors, it is the large bulk of the clinicians are salaried doctors, and salaried doctors or employed doctors generally are more fluid and move more than the partners do, and that's why we would always want to attract more partners, because it does lead to stability. But the answer to the question is yes, and we in fact today one of our salaried doctors is leaving. It's his last day. I've got a card somewhere for him which I'll be passing on to him, and we have been interviewing this week indeed for a replacement for that doctor. So yes, there are vacancies. In terms of the nurses, I don't believe we have a vacancy currently. Mandy might know better than I, but I think we have recently recruited another practice nurse, and we're just going through waiting for references, etc. So I hope, does that answer your question?
Yeah, so to clarify, we've probably got 1 doctor vacancy at the moment and no nurses in terms of vacancy at present, although I appreciate that's obviously going to be fluid.
Yeah, I think that's right, and Mandy will correct me if I'm wrong.
Okay, thanks. Sorry, I should have said my name's Suzanne Horrell and I'm a lay member for the CCG in governance.
Thanks, Suzanne. I'm conscious of the fact now I've got a few people who are wanting to speak. Some of you are actually sending your messages to the entire audience, and you should really be just focusing it on organisers and panellists. And I know that Paul Bone wants to speak, but for some reason it hasn't come up in the chat box. But I'm going to go in order. Neil, you were the next, I think, that wanted to speak.
Yeah, thanks. Just got a couple, Mike. One of the things that has been referenced by John and the Save Our Surgery group is about the difficulties with travel, and clearly one of the points that you made in your presentation was about the different model now being operated in terms of much reduced face-to-face appointments. I guess one of my queries was around the proportion of appointments that were historically delivered at Sandyway that were urgent. Because of course the part of the argument is you have to plan travel in advance if it's more difficult to travel, and clearly if a lot of the appointments delivered were urgent, it's a much greater impact on the local population than if they were generally routine and people were already travelling to one of the other two sites for urgent. I need the documents, so I wondered if you had a feel, you or Mandy, around what proportion of the activity at Sandyway was urgent.
So yeah, again, thanks, Neil. I can take that. We run a system where we have a proportion, or prior to the new system, and we have a proportion of book on the days, as they were called, or urgent cases, if you like, and a proportion of follow-up cases in each surgery. It really is pretty much off the top of my head, but I would say that the majority of the appointments offered from the Sandyway surgery historically have been follow-ups, so non-urgent work. There would be some appointments which would be offered at the surgery for patients who've got an urgent need, or indeed sometimes patients, as has been explained previously, would walk into the surgery, and that's true at Danebridge and Kingsmead. So we'd have to have provision for that. So it's mainly follow-up or non-urgent work which is done at that surgery.
Thanks. And sorry, can I just ask my second question whilst I've got the mic? My other one was, one of the points you made was around the not having had the planned focus groups for obvious reasons in relation to the pandemic coming along. I guess my query is, if the committee were to approve the application today, and recognising some of John's points that the local community, some of their queries relate to not being clear on what the future looks like, would the practice have plans, or more importantly, a commitment to actually run that kind of focus groups to work through with the local community how to minimise the impact on them? I may be asking a leading question there, but I think you probably get my tone.
Yeah, thanks. Yeah, undoubtedly we would want to work with the patients, the residents, and the Residents Action Group in trying to make things work as well as they possibly can for that group of patients. If the panel were to choose to decide to close the practice, that would be very much in our interest and very much in the patient's interest. You know, we have cared for those patients for a very long time, and that is not about to end if the surgery were closed. So certainly we would want to engage in a dialogue with them and take that very seriously. So certainly we would, yes, of course.
Thank you.
Okay, I'm going to ask Mike Clark to come in now.
Hi, thanks, Pam. So Mike Clark, GP in Macclesfield and Assistant Clinical Chair to CCG at the NHS Cheshire CCG governing body. So one quick question, well, two quick questions. The first one is there a particular reference in CQC report to the Sandyway premises? That's the very first quick one, just to clarify. But the main one is more, again, just teasing out a little bit of the issue about workforce on the Sandyway sites. If I'm right, I assume most of the doctors working in Danebridge Partnership aren't full-time. So if we factor in the possibility that we're not looking at whole-time equivalents when we look at the numbers of doctors, and the population that are covered by Sandyway surgery is probably about 14% of your total population, I'm working out that that's probably 1 or 2 doctors to manage Sandyway surgery, but probably erring more towards 1. So again, it still leads to the point, could you ever envisage a time where you would need to put in more than one doctor at a time? So that still comes back to your point about lone working for salaried doctors. They don't like to work alone, and they would need that additional cover. So can you ever envisage justifying having 2 doctors on site all the time in order to open the practice for the full hours that you intend to open the practice? Or are you realistically saying you can never man it with 2 doctors, or you would have to cut down the number of hours that you would be covering the surgery? Could you just clarify that a little bit?
Okay, thanks, Mike. So your first point, from what I recall from the CQC report, and again, Mandy, please correct me if I'm wrong, but there was reference to it needing decorating and some, I can't quite remember the phraseology, but certainly a reference to renovation or refurb or something along those lines. There wasn't a great deal of detail regarding that as far as I can recall. Your second point, the difficulty we have is with 3 sites is manning all the sites, and Sandyway is one part of that. And that's where our difficulty lies, in being able to put more than 1 doctor in there for essentially what would be 2 sessions a day. We have found that historically very difficult to do. Am I saying that we would never be able to do that? One can never say never, but with the numbers of doctors and clinicians we have currently, which during a recruitment crisis, I think it would be extremely difficult to man that surgery adequately and safely. We don't, you know, it was mentioned earlier, and I don't want to get off the question too much, but it's not a matter of putting junior doctors in Sandyway. It's about putting a mix in there, a team. And a team, yeah, 2 can make a team, I guess, but really you need more than that in a team for the flexibility, the expertise, and safe working. So the answer to your question is, I think it would be extremely difficult for us.
Okay, thank you. I'm going to bring in Paul Bowen now. I know you've got a question for the LMC, Paul, but if you just do the question for the surgery first, we'll take that after.
Thank you, Chair. Mike has asked a similar question to that what I was going to ask. My name's Paul Bowen. I'm a GP over at Poynton in Cheshire. I was looking specifically at the actions to mitigate the safety issues. You raised a number of issues, Mike, in your rationale for the closure, many of which are around estates or what have you. But one of the arguments you make is around the safety both of patients in terms of access, but also the safety of staff providing things in a lone working. Have you calculated the potential costs involved of making the service safe from a point of view of workforce, irrespective of their availability? We all know that, you know, there is a recruitment issue with both general practice and practice nursing and what have you. But in order to ensure a safe service at Sandyway and defining safety as individuals who aren't lone working, was there any effort to look at the investment required and the ongoing costs in terms of having more than 1 GP, maybe a GP with a different type of clinician, perhaps a PA, pharmacist, etc., so that there isn't lone working, recognizing one of the rationales that you make is around clinician and patient safety?
Thanks, Paul. I think the simple answer to that question is no. We've not looked at that specifically. I guess when we look at safety, we in our minds, it's very much wrapped up in the issue of lone working and the environment that the doctor's working in. But in terms of actually looking at an alternative solution to staffing Sandyway surgery with alternative clinicians or a specific clinician, We haven't looked at that. We certainly haven't costed it, no.
Okay, I've now got Gwydion, then Paula and Wendy. Gwydion?
Thanks very much, Pam. Gwydion Rees, I'm a GP in All Sager and a GP on the governing body. Thanks for the answers so far. I just want to dig a little deeper, Mike, if that's okay. So John Kerrigan gave, I think, a brilliant pitch, yeah, and he spoke about maintaining what they have. And I think and I'm going to misquote what he said, I think he spoke about modernising or improving. I think I understand the practice perspectives from my position as a partner in a practice and the difficulties that are faced when you're trying to maintain what is in essence a small branch surgery. And I don't think those difficulties have been adequately teased out yet, because I think this comes down to a question both of what is safe for patients and also what is actually of viability to a business. And I was wondering if you could elaborate a little more for me, because I think we've tried to touch on the differences in quality. And I think the video that I saw of the premises contrasts quite starkly with the room that you're sat in, for example. Now that has a lot of knock-on impacts for patient experience, it has knock-on impacts for recruiting staff, and we've spoken about lone working. And yes, with infinite resources, you could put lots of staff in there, but we're talking about business viability. So, you know, I'd like you to get another opportunity to explain to the panel, you know, if you were to keep Sandyway, so if this was an ideal world, what it would require with regards to capital investment, where that investment would come from. So would it come from partner investment? Would it come from a grant? Would it come from the CCG? But also, what type of investment would it require with regards to partner and GP staff time? Because that often isn't costed into the equation. And also, how difficult it is to actually maintain the staff and resource. Because as an employer, I know that's hard. And I know it is difficult when you're asking staff to work across multiple sites. And also about the added difficulty of ensuring safety. Because I think the danger here is that we look at providers with dual standards. So we often come across hospitals and other providers saying that a particular service is not safe, or it's not viable, or they can't maintain it. Whereas I think what I'm looking at here is a service that's been there for a long time, is obviously valued, but has probably been providing a substandard service for a long time. So what I'm asking is for you to explain, well, what it would take to provide the same standard that you feel a patient coming to see you in one of your other two sites gets.
Okay, thanks for the opportunity to answer that question. Yeah, I think in terms of the costs are both financial and time. I agree. It'll be a major project for us if we were to renovate that property, which will take up an enormous amount of our time, both as management and as partners. Undoubtedly, and I think you're absolutely right, that's a cost which is often overlooked or not recognised fully. In terms of the finances, well, the quotes that we've had, if we were to look at a renovation or a refurb of that property, bearing in mind what William said about often it can be more cost effective to demolish somewhere and rebuild it, and that was the cost of that was in excess of £1 million. But a refurb or a renovation, we've had a number of quotes through, and they're coming in at around a ballpark figure, I guess, of in excess of £300,000, which is undoubtedly a lot of money. For a partnership currently, my understanding of how the finances would flow is that we would request some capital investment from NHS England, as I understand it, but we would be expected to pay a third towards those costs. So you know, we're talking £100,000 or most likely more, I would guess, because these are just initial quotes or estimates, if you like. That money, my understanding is that the additional costs of the excess or the balance would be paid ultimately by the practice over the longer term. I'm not quite 100% sure of how that works, but certainly the partnership will be expected to provide in excess of £100,000. Now that is no small sum of money, and as I said, that would certainly, in my opinion, our opinion, that would potentially destabilise the partnership. There are partners, it is a business, there are partners who are approaching retirement. One doesn't know, but that could speed up that process with partners wishing to retire earlier than they would have done otherwise. Finances often dictate when a doctor retires. And undoubtedly it would have an adverse effect on recruitment. I cannot see doctors who would join our partnership taking on additional roles, additional work, additional responsibility, and essentially having to pay for the privilege of that with an upfront fee, if you like, to invest capital. And I think that would make it extremely difficult for us to replace inevitably outgoing partners who will inevitably be leaving at some point anyway. I think you make a very valid point. We have been offering a service, a substandard service, I think, from Sandyway Surgery for some time. And it really was the CQC visit, which, although it wasn't in detail, it was that event and that response and that outcome that the practice received, which made us think closely about how we want to proceed. But certainly from a business point of view, that amount of money, I think, would have an adverse effect on the practice partnership, which in turn would have an adverse effect, I think, on patient care ultimately. It may be insidious, but I think that would happen with time. I don't know if that answers your question. I hope it does.
Okay, thanks for that, Mike. I'm going to bring in Paula, if I may. Paula.
Thanks, Pam. I'm Paula Wedd. I'm one of the directors that works for Cheshire Clinical Commissioning Group, with a focus area on quality and safeguarding. Thanks, Mike, for the points you just made in answering Gwydion, actually, because that speaks to one of the questions I was going to ask. I was going to explore this issue of substandard isn't always safe. And I'm sure you wouldn't want any of your patients thinking that you've been delivering an unsafe service. So, and I think it's about, you know, you've clearly done your best in perhaps challenging premises and with challenging staffing levels to deliver as high quality services as you can. I think there is something about being aspirational for it being high standard, as opposed to some of the language that we've been talking about today. I wanted to explore the issue of, you know, what it would have cost to get the existing premises rather than the new premises to a point at which you could deliver a high standard service rather than thinking about substandard, which are some of the words that have been using. And you've answered that question to Gwydion. And I guess I was then going to be thinking about, given that it's linked to a key service centre, would there be access to any additional resources or grants or other funds that perhaps wasn't previously cited or aware of? And that was a blind spot for me, so I was interested in that, because actually the answer that I think I've just heard in terms of business sustainability that you've given to Gwydion was around the fact that actually to invest that sum of money using the standard approach through NHSEI and then resourcing from partners may actually put the partnership at risk, which actually means we actually wouldn't have a practice and doctors available to deliver the service. And that's quite an uncomfortable thing to say. And I'm glad that we've had the opportunity to discuss that. So my question, prior to Gwydion asking his, was really about what would be the impact on yourselves as a practice in terms of being able to upgrade the building and to deliver a high standard of service from there. But I guess I will be moving on from that then in terms of the answer you've given to actually knowing what other funds or resources may be available for this key service centre that we've heard you know, some strong information today about the benefits of being part of a key service centre.
Okay, thanks, Paula. Yes, I think the term substandard is perhaps a word I picked up on. I wouldn't. I think we have struggled. It's been a challenge to offer the standard of care that we need to at Sandyway Surgery. I wouldn't say that we have been offering a substandard level of care to our patients there, but it is proving an enormous challenge in order for that to continue. And certainly I agree, we do aspire to the high standards at Danebridge, and we want to offer that to all our patients. In terms of other funding options, I'm afraid that is not my field of expertise, I would have to say. I cannot answer that question. I just don't know what options we have or would have. We have focused very much on the quotes and estimates we've been given, and my understanding is that we would be expected to invest a third initially of any renovation project for the surgery, and a third of the costs. That's always been my understanding. I don't know if there are other options and other ways of raising capital and funding renovation or rebuild, etc. So, Paul, I'm afraid I can't answer that question fully for you.
Okay, I'm conscious of the fact we're wandering into the realms of debate here, so I'm after questions for clarification. Wendy, have you got a question?
Briefly, because I think people have already been asking the ones I was going to ask. What particular point, Mike, did you actually decide that Sandyway was going to close?
Thank you, Wendy. At what point did we actually decide? I think it is something which we have, in all honesty, debated over a length of time, I think. We have recognised all the arguments that we have gone through already today, the challenges of Sandyway Surgery, but always have decided that we would wish to continue offering that service. So in terms of when we decided that that surgery was to close, I think, as I said, the CQC visit was a catalyst for that decision. It may not have been the specifics of the report, but it was at that point, I think, if you like, the penny dropped for all of us that we were being held to standards which we, as I've explained in the previous answers, struggling to offer the quality of care there which we wish to. So once that CQC report had been received, that's when we were having serious conversations about a number of changes that need to happen in the practice. This was one of them, albeit it's one which is having clearly the biggest impact on Sandyway residents. But it has been part of a number of significant changes, really, lots of clinical changes we were criticised in terms of leadership and safety. But yeah, the decision was made then, soon after that report, was once we'd had time to reflect on it and discuss it.
Okay, thanks, Pam. I'll leave the rest of my points to our discussion.
Okay, thank you for that. Susanne, you wanted to come back?
Yeah, thanks, Pam. Mike, just two quick points for clarification. One, you said about looking for additional parking at Danebridge, whether you had found any. And two, does the practice have a lone working policy?
Thank you, Suzanne. In terms of identifying additional parking at Danebridge, no, I'm not aware that we have approached anywhere formally in terms of trying to look at where additional parking could be found. Just talking off the top of my head, we have used additional parking recently during one of our weekend flu clinics. So there is a large car park which is a matter of 100 yards away, just behind the practice, which is currently being, historically has been a supermarket car park, but it is extremely large for the size of retail facility that's there. That is something we've asked. I think it's currently a charity shop which is currently closed because of the pandemic. Mandy will know better than I, but I think we approached the council to use that car parking space during recent flu clinics. Whether that would be an opportunity for us to explore more in the future, I don't know.
Okay.
And your second point, do we have a lone working policy at the practice? You are asking, yeah, you're asking exactly the right person, because I'm the health and safety lead for the practice, but my manager Ken mainly does the detail. I think Mandy's going to say something. She probably know best than I.
Can you hear me?
Yeah.
So Mike, so Suzanne, yes, we do have a lone working policy at the practice, and it's actually Care UK have been operating in the period that we did our flu clinics. Care UK were operating, so I actually spoke to Care UK, the charity who are running the centre, and they agreed to us using that facility over the when we were running flu clinics. So yes, we could approach Care UK again and see if we could use that facility as additional car parking.
Okay, sorry, I thought you were answering the lone working question.
I've done both.
Confused.
Okay. I'm conscious of the time, everybody, and I know that Andrew wants to come in, and I also have some other people might have other questions. Andrew, question? Or is it William? Sorry, William wants to come in.
No, I just answered the question before.
Sorry, Andrew. Sorry, I've lost my chat box. Andrew, sorry.
Okay, I think I found the part in the papers which I wanted to refer to. Sorry, I'm Andrew Whittingham, I'm Associate Director of Finance for the CCG. I was only going to ask if we'd also considered, as part of the consultation, about patients travelling by train to surgeries. Because I think, off the top of my head, there is a train station at Cuddington that goes directly into Northwich. So is that another option that they would have considered when looking at how far patients would have to travel and to how long that would take?
Is that question to me?
Yeah, Mike.
No, I don't. We haven't considered the train service. No, it's a simple answer to that question. I'm not quite sure whether, probably John Kerrigan would know best than I. I'm not quite sure where the train station is. I know there's one in Hartford, but I'm not sure.
If it's any help, Andrew, I'm on that line, and the trains run once every hour, and they don't run very early or very late. So, and it's such a distance to get from Sandyway to Cuddington, and also at the other end from the station to Danebridge, and it doesn't go anywhere near Kingsmead. So I don't think it's an option at all. John, do you agree?
Pam, is it near Whitton Street? The train station in Northwich.
The train station in Northwich is right up by Tesco's. It's right at the other end of Northwich. So you're talking probably nearly a mile walk from the station to you're probably better off walking from Sandyway than you will be going from it's a long walk. Yeah. Okay. I'm going to move on because I'm conscious of the time. It's 4:45. I know that Paul Bowen, you've got a question for the LMC. So do you want to do that now, Paul?
Thank you. This is really one about the figures and evidence to William, really, and with regards to whether there's a national position with regards to safe staffing levels in practices. I recognise that there's approximately around 100 consultations a week, 20 a day. I assume it looks like half of those are nursing, half general practice, or possibly even more general practice. But we understand that whilst convenient, there is an issue with regards to safety, and I wondered whether or not there was any evidence nationally or any position that the LMC has or the GPC has as to not the maximum number of appointments in a day, because that's a hotly contested subject as to how much GPs should be doing, but the minimum, and whether there is a position that was looked into either by the practice but more like the LMC on their behalf as to whether there is a generalised standard of care expected from a minimum number of GPs and other health professionals in branch surgeries or small surgeries, given the agenda around reducing the number of single-handed GPs, many of often because of issues around safety, not just for patients but also for the staff there. So was there anything, William, that you could provide the panel with regards to the LMC's position on minimum practice size?
There are no national standards on that, Paul, in terms of sizes or ratios for staffing, etc. There used to be about 40 years ago, 50 years ago when I first started, but there is not now. In terms of lone working, again, there aren't any national policies on that, but at LMC, we're very much against lone working, and we have stated that in the past.
Okay. Does that answer your question?
And for what reasons, William?
It's both practical experience and national cases reported of violence and abuse against both GPs and practice staff. It is unfortunately a growing concern. I can't give any figures off the top of my head here, but it is an issue that unfortunately is growing. It's for all emergency workers, really.
Okay. I'm conscious of the time, as I said, and I'm wondering if anybody's got any further questions for the LMC or any for John, who's sitting there patiently. And I've noticed that Mike said he's got a question for CCG colleagues about the overview and scrutiny comments and MP comments. Are they questions, Mike, or are they, can we leave them till after we've had a comfort break?
We can leave them till after the comfort break, absolutely.
Is that okay? And Neil, yes. You've got one for John.
Yeah, John, I recognise that a large part of your concerns were about not being clear on what had happened, but I wanted to focus more on the length of the consultation, which is a key part of the point that you've made. When I look at the percentage uptake, it's clearly been a very, very engaged local population in terms of number of responses. And I guess, do you think if the consultation had been longer, it would have had any impact to the outcome? So I'm not getting into the point you made around the fact that some of the arguments you think weren't clear. It's more around that point on length of consultation.
I think the consultation, I didn't raise the issue when I was speaking, but there actually is a bit of a conflict about some of these dates because the consultation was indeed very short. It wasn't from the 13th of December to the 29th of January, which is what it says in the papers. It was from around about the 19th of December to the 27th of January. So it's a 5-week consultation, not a 6-week plus consultation. I think the engagement of people over that period was remarkable, and I think we've seen in our papers that we had some close on 900 people have signed up to support the campaign that we've been running. I think whether the consultation would have been better had it been completed, and I think what we got, and I know that Dr. Mullin and Mandy know this, is that we got basically 2 interactions with the public, neither of which went to plan. In everybody's estimation, not just the practices, but in our estimation too. And I think Dr. Mullin mentioned the fact that the focus groups didn't take off. I think they would have been a fundamental benefit to this process had we been able to engage in that process, because a lot of ideas were coming forward from patients which we've not been able to follow up on. Indeed, including things like crowdfunding and local funding for improvements. Now, what I have learned in this process, which is, I was a bit surprised. I never realised that GPs were subcontractors to the NHS in the way that you are. So it's a rather different scenario than, say, working with a council or something like that. But having said that, I think that a longer engagement would have been better. Would have given patients time, first of all, to understand fully what the initial issues were, which were not really that clear. And secondly, as the debate has developed, we've moved, as we said in our presentation, the ground has shifted significantly from the state of the assets and issues of safety, safety exits and carpets and all that kind of stuff, decoration, to lone working and much more strategic issues, if you like, for the NHS and for your colleagues. And I think that is not at all understood by the patients. And I think the patients would happily engage in looking at what exactly are the implications. And Dr. Mullen has said himself there that a lot of the stuff hasn't really been looked at by the practice. But what are the fully costed alternatives, etc., to your questions. So I think the patients would be willing and able to contribute to that, and would probably help to get a better outcome for Sandyway, because we still end up with this big question mark: how is primary care going to be delivered effectively if Sandyway closes? And we're not convinced, and the patients are ignorant of what ideas there are. And frankly, I'm not sure I've heard that many ideas today that say to me, well, it's all in hand, it's all under control. I think there's a lot of work still to do before anybody starts talking about closing Sandyway. And I think, you know, we're talking about closing a surgery here, and it's not a retail outlet. So the alternative is, oh, well, we'll close the surgery, but you can go online. Well, you can do that for Marks and Spencer's. But this is health and welfare we're talking about here, and it's a different type of topic. Understandably, it's got to have financial sense behind it. Understandably, it's a private business. We understand that now. I certainly didn't understand that, but GPs are private businesses. So they have to look at it from very much a commercial side as well as the caring side. And I'm not suggesting that the doctors don't care, but I am suggesting that there's a balance here that we would like to engage more in and understand.
Pam, I think you're on mute.
Sorry, pressed the wrong button. I'm going to suggest we take a break now. It's 15:54. So can we do it in 6 minutes and come back at 4 o'clock? Is that all right? Yeah, lovely. I'll see you in a few minutes.
Forward a really good argument about how the local residents value that service. It's obviously do. The engagement that they've achieved in a short period of time is massive. And I think he's starting to understand more the point of view of the practice, i.e. that it's not the practice that's saying, well, we just don't want to look after you because it costs too much. That's not what they're saying. What they're saying is we're worried that this will take away our ability to care for the rest of our list going forward. You know, which is a different thing. I think the problem for us as a commissioner is deciding, well, okay, for every pound that we have, how do we make sure we get best value? And for these patients, it sounds to me as though there needs to be an investment if we want to maintain that service in that locality. That's how I see it anyway. So I don't know if that's given Chris a little bit of time to come in and maybe say something a bit more cogent.
We've got some other people wanting to come in as well. Paul, did you want to come in?
Thank you. Yeah, I feel that we are missing some information, and whether or not because of our experience we can fill the gaps in that information, or whether we need to formally go out there. The three areas I'm still left with, and I tried to tease it out from Mike a bit, and to a certain extent from William. I think I don't think we should be distracted by the costs of improving the facility, the thinness of the walls, the parking. They are all issues that, you know, can be overcome. For me, I think the first thing I feel I needed to establish is, how do we make the service in this practice safe for the long term, given the strategic direction of the NHS at the moment, given the PCN movement, given integrated care and ICPs. Can the service delivered by this building, because buildings don't deliver services, people do, but is it possible to put the right people in this building to maintain a safe service, avoid the lone working, give the support and supervision to the staff there, and embed good quality general practice? And what would the ongoing costs of that be in terms of the financial cost to the partnership, or the removal of skills from the other two partnerships to maintain that? And I still don't feel I've got a true, I can make an assumption, I'm assuming it will have to be another GP, you know, and another GP that potentially might be twiddling their thumbs. Not that I'm sure they will be, because now we're doing a lot more telephone and online. But I was trying to establish, have you looked at bringing in a PCN member of staff, a PA, a pharmacist, or someone to support the lone working issues that seem far more of an issue than the thickness of the walls, which are more amenable? What I also didn't feel is, what were the benefits to Danesbridge partnership as a whole, and to the patients of all three sites, by focusing and consolidating all your skills into the two sites? Were you able to potentially increase your offer to everybody by bringing those skills and resources that you've currently got at this one practice into the other two? Is what you will lose replaced by, is the gain bigger than what you've lost, in terms of, do you have plans to you know, to extend your service to the people across all three sites? And lastly, I didn't get an impression of what the mitigating actions for the loss of, it is very convenient having a practice in a small site. You know, it's not many places now would say, we're a village of 3,000 people, let's build a surgery. It's relatively, but the cost of losing something you've had for 100 years is far higher than going to somewhere like Titherington that hasn't got a surgery and say, would you like a practice? Yeah, that's that. But I didn't get a sense of whether or not there'd been some mitigating actions to say, listen, we know there's only 5 buses a day, and if we have to see you, we will plan our services around so that we will see you and you can get your return bus back, and you're not spending the whole day in Northwich and what have you. So I didn't get a sense of some of the mitigating actions to compensate for the loss of convenience in order to get safer services from that. So they're the 3 areas: the cost of maintaining the ongoing safety there, and whether that's an impossibility, the benefits to everybody for consolidating the skills together, and the mitigating actions in terms of convenience for people having to now travel into Northwich.
I don't know, Mike, if you want to come back on that, but I also know that Chris is now unfrozen and has offered to answer the initial question that Paula raised, or tried to. So I'm going to bring Chris in first in terms of the risks. Chris.
Yeah, so apologies, I could hear you, but my little control pad had frozen over all your faces, so I couldn't get out of it. It wasn't fear, don't worry.
It did look like fear, Chris.
Oh, well, I must try harder.
Can you, I think it was fear that your system had frozen, which is a fear of mine as well. Can you give us some indication of what you think the risks are if we voted to have the surgery closed, as opposed to if we voted to have it remain open?
So I guess the risk would be some of which you've outlined. I think it's just important that I say again at this point that this isn't talking about withdrawing services from a population. It's a site in which services are delivered. So many of the GPs on the call have probably quite large practice boundary areas which cover rural areas, and the patients in the very corner of those practice boundary areas can expect the same level of care as somebody that lives down the road. And I don't think it's probably fair to use Danesbridge as an example of why that wouldn't work if Sandyway wasn't there, if that makes sense. So you do treat all your patients the same regardless of where they live. And in rural areas, it is particularly challenging because of the geography involved. So the risk would be that the patients that are using that site conveniently now won't be able to go to a building. It doesn't mean that they won't have access to clinical care. Does that make sense? So it's going to a building down close by, which is, I can entirely understand it, is very, very convenient. But I think the practice have already articulated that the services they offer at that branch are appointments with GPs only. So general medical service delivered by GPs. I think Dr. Mullen articulated that pre-COVID it was mostly follow-up, which I think is right. So patients would theoretically have to travel to one of the other two sites for anything over and above that. I think I've captured that right from the application. So and the other thing to say is I'm not making a sweeping judgment call about all branch surgeries in the UK, but it is quite common for branch surgeries to be on the small size, sort of building wise, and also it is common for branch surgeries to not offer as much as a main surgery just because of the very nature of them. So I don't know if that helps, Pam. What you're looking at is a population that have been used to having something on their doorstep, but there are pockets of populations elsewhere that don't have a branch or a building on their doorstep. So I don't know if that's helpful or not. If I can just give the opposite, which is I think the practice have articulated, I just think it's worth repeating. As somebody that's worked in a practice myself, the challenges of operating across 3 sites should not be underestimated, regardless of the arguments that are being given by the practice administrator. That I think we would all acknowledge that is a challenge. That is a challenge.
Okay.
Does that help?
Yeah, it does help. Thank you. I'm conscious of the fact that Mike still has some outstanding issues from before the coffee break, and also that William and Suzanne want to come in. So, Mike, do you want to go first?
Yeah, I'll try and be quick. 2 quick points. And again, it's sort of what's not said in the OSC and the comments from the MP. What's not picked up is that we have a risk here of blaming the practice for there being an inadequate transport infrastructure. So what I would say is we should be reflecting back to colleagues in the council that this situation could be improved to some extent if there was a better transport infrastructure. So that's the first point. And the second is, again, both to CCG and local authorities, we currently have primary medical care services on that site, but have we explored the possibility that if the practice can't maintain services there, what other care services, community services could be provided from that site that still helps to maintain a presence for the NHS or some other services, rather than it being a burden for the practice. Again, just 2 contentious points to raise to take the debate out further.
Okay, I'm going to bring everybody in and then hopefully open it up so people to say what they think. William, you wanted to come in.
It's really going back to your original question, Pam, about what's the risk. I mean, the ultimate risk, and I don't think this would happen, but the ultimate risk would be the practice would fail to recruit partners, would survive more and more on salaried doctors who do not invest in the capital development in a practice, and you'll be left with 1 or 2 partners who at that point, and this has happened around the country, would probably hand the contract back, which would then mean it's the CCG's responsibility to find medical cover for whatever, 20, 30,000 patients. So that would be the ultimate doomsday scenario. I don't think that's going to happen. But the problem, I think, and I think Dr. Mullen did articulate this really well, and others have echoed it, the way in which GPs have contracts with the NHS is completely different to hospitals and community services. They are, and always have been, independent small businesses. So whatever money is available through the NHS, through grants or whatever, premises improvements, usually the capital cost falls to the GPs to raise the loan. So that is another loan that they are taking out. And this is why we can't get new partners into the system nationally. So I think that's one side of it. I think Chris articulated some of the shorter term issues. I think most practices are looking at reducing branch surgeries. It's a national trend because of the costs and more likely the workload and workforce implications. And again, I think Dr. Mullen articulated that. I think from the patient point of view, if I put my PPG hat on, then I think John's group have done really well to articulate all the issues around that. But a lot of them are not NHS system issues, they're system issues, they're social society issues. And I can't think we can discuss those here today, but they do play into this. So are there alternative ways of providing medical services in that patch? Probably is the answer. It's not my job anymore to work out what they are. I'll leave that to Chris and Neil and colleagues. That's what they're paid to do now. But it's a long-term solution. I think the short-term issue is the workforce issues in the practice will not get better until this is resolved.
Okay, I know that Suzanne and Wendy waited to come in, but I think Matthew wants to pick up an issue on the transport. Matthew?
Hi, just to really respond a little bit to what Mike was saying. So the issue around public transport, you know, again, it's not necessarily the local authorities' role to provide that kind of public transport. In the same way you quite rightly said, it's not the NHS in terms of those sort of things. What I would say is, though, is that we have been contacted by Cheshire West and Chester Council with regards a future piece of work that they are doing around a review of the public transport across Cheshire West and our involvement in it, and how that potentially will hopefully facilitate an active lifestyle just as much as, you know, how can it help to support maybe such issues with this. However, you know, we're not in it yet, and so in some respects it isn't something that we can really factor in today's conversations. But I think, you know, we do have to recognise, you know, public transport is a challenge for whatever public organisation, and I think that has been recognised in some of the conversations today. And whilst there are lots of alternatives, there are lots of challenges, and, you know, whilst train and railway and bus and all this lot, the same thing, I know, are options, it's not as convenient. So I also like to echo really what Paul was saying in terms of, you know, recognising the restrictions around public transport. There are potentially ways to mitigate that in terms of the offer. So I was really interested to hear Paul's view on that one. But just again, just to reiterate, you know, the council are looking at this, and they have invited us as a CCG to play a part in that review.
Okay, thanks, Matthew. Suzanne, you wanted to come in.
Sorry, are we moving on to the debate and feedback now? Yeah, okay, fine, I'll go. There's a couple of individual points to raise. I think William summed it up quite nicely earlier on when he talked about this being a financial case, about looking at stability. But I have to say that is not what the application talks about. The application does not talk about the viability of this business. Now, I'm an accountant, I can read it and I can read between the lines and I can understand exactly where the business is coming from. And in that context, I'm not unsupportive. I absolutely get why they are struggling. However, the application does not talk about financial viability of the practice, about partnership arrangements. They are self-employed, they are not employed. It's a really difficult balance to get. But if I'm to judge an informed decision based on the application doesn't support that discussion and debate about stability of practices and financials. The fact that it's been hinged on the CQC report, which actually doesn't say there is a risk of harm to patients, or there is a service being delivered that is below standard. Yes, the premises don't appear to be as nice as a lot of other premises, and I fully back that. But it doesn't talk about lack of safety and provision for the patients there, which seems to have been flagged. So I disagree with that angle, and I think there's a business case, quite honestly, been hooked on to CQC report. That's how it feels to me. And in terms of the branches, yes, I understand that they are closing. I live semi-rural, not there, somewhere else. There is no bus service. I'm 5 miles from any GP practice, but I chose to live here with knowing those circumstances. And I think when I look at what the CCG is trying to achieve at the moment in the long term, and about working closer to home and in the community, I understand I don't want to maybe operate it as a GP branch, but I'm really disappointed that we've not started or had discussions about what else it could be. how else it could be used and what else it could deliver in the community. And maybe that's not for the branch to decide, but the fact that, you know, there's a whole group of people in that village who have been willing to come forward with ideas, with thoughts, what they would like to lead as well locally, and none of them have been actioned. And I'm seeing a real lack of action on addressing some of those issues in terms of blood samples, in terms of prescribing. I've got aged parents who use the IT equipment, but they're not on e-prescribing. So in COVID, that became a real issue of them going out collecting and dropping off scripts, which I didn't want them to do. So I think, you know, we've not picked up those vulnerable groups, and we've not addressed some of those issues. And I think the practice could have done a little bit better doing that and helping and giving that support back and that assurance back to the community that, yes, okay, it's not going to be as convenient on your doorstep, but we are doing these things to help you. And I understand transport can't be one within their gift, but I do think the practice haven't helped themselves either in the way it's been presented. I'm not saying they haven't got a case, I'm saying it's not what they've presented. Thank you.
Thanks for that, Suzanne. Wendy, do you want to come in?
Yes, I do, but I think Suzanne's actually stolen my thunder. I think that I understand completely what the practice need to do and why they need to do it. I don't think I'm challenging the resourcing issues that they're finding a problem. And obviously working across 3 sites is complex and problematic. I think that whilst I accept those logistical difficulties, I do wonder that they didn't actually articulate in the business plan that option appraisal for alternative ways of doing it. Did they think of closing either of one of the practices that were close to each other, for example, so serve a different population? I'm not really sure. I saw in the business case that they did a real impact analysis on patients. There's an impact analysis on safety and quality of provision of service within the practice, but I didn't really hear, and it builds on what Suzanne was saying about how it really affects the patients in that locality. Withdrawing service is always problematic and is rarely a plus for those patients, and especially as the demographics in that area are actually actively acting against it, and also that there is plans to build a lot more houses in the locality. So I felt that the business case was not strong. I understand the aspects of the business case, but I felt that they were not really arguing the reality of what it is actually like to withdraw provision from people within a locality who are often vulnerable and really do need that closeness and feeling that they know their GPs, that they can go to their GPs on an as and when basis, and that they're truly cared for in their locality. So I have reservations that the business case was clear enough, strong enough, and maybe we ought to be really thinking across the patch in Cheshire about how we are going to address the needs for us to make sure that we take that care closer to home, that we expand our general practice to accommodate a much wider range of services, and to make sure that we do that effectively for the future. So it's a very mixed bag for me, I'm afraid.
Thanks, Wendy. Paula, I'm conscious of the fact we might not have answered all your questions. Do you want to come back in?
Yeah, thanks, Pam. I think it's because we've heard new information today that I didn't feel I was cognizant of in terms of reading the business case. I think a number of people have pointed that out today. So I did have a set of information in my head. I was very much aware of the phrase used around that kind of, that conscientious decision making and that, and putting the time into reading all of it. And I had in my head about CQC. I was looking at the mitigations for appointments, for prescriptions, for samples, some of which I could see mitigations offered, some I couldn't. But it's different information, I think, that we've spent some time talking through today. And some of that really was about the so what. We've talked about sustainability of the business model, but we've also as well had some strengths of a case for a healthcare model, or possibly a health and social care model. Actually, we listened to some of the points that Paul's raised earlier about thinking about population needs, and I still can't move away from perhaps understanding what it means about this key service centre. So I'm not sure that that point's been addressed for me in terms of understanding the impact of that and perhaps access to other resources and what that would mean.
Okay, I'm just looking at the message bar. Sorry, yeah, Matthew's made a point which we've talked about quite a lot over the last few days. This isn't a business case that's been put forward; it's an application to close. I just need to. That's a distinction that we need to bear in mind. Paul, you've asked to challenge something that's been said. Paul?
Yeah, I appreciate that we might want to consider how this facility could be used in a more integrated way, but the nature of the legislation is that we're a primary care committee and we have to consider it purely from a basis of primary care. If this was a mental health facility closing down, and I've got the scars to prove this as CCG chair, we would be considering this in the same way in terms of looking at the whole picture and considering this. But the primary care committee exists to consider primary care issues, and therefore I can foresee that if a decision is made purely from a primary care provision point of view, then it may have to be escalated through the CCG in large about how you maintain health and well-being of the population of Sandyway and beyond. But for me, that's not the remit of this committee as far as I understand it, because we are in that bubble of looking purely at the primary care. But I would want to challenge that the application clearly in section 6 identifies the risks and the rationale focusing on safety and staff without clinicians. And I was seeking to understand the LMC's position on this, and I think it is a real risk, and it is explicit within the application that yes, there are some capital issues and some estates issues, and John very well outlined the impact on convenience and to a certain degree safety. I'm not saying it's not just about the convenience of having a local surgery. He's indicated that yes, there are people who may be impacted from a safety point of view, but I've actually been reassured that actually, given the fact the majority of care is follow-up and the majority of safety issues come when you can't access emergency or urgent care, and I've also been assured that a lot of that is now and will continue to be provided by telephone. I'm not suggesting that everyone should go online, but I know the surgery continues to provide telephone and visiting services. And I've also got assurance that they'll continue to be able to provide continuity with their GP, whichever building they're in. Then I think the application clearly outlines the rationale that aligns to the conversation today and highlights that it's the safety of ongoing services versus the safety of not having a surgery you can walk to, which captures me as a clinician. My issues is in terms of the clinical outcomes, what's the greatest risk here? The loss of a local surgery that can provide some follow-up to a relatively remote population versus the impact on this business to be able to provide and recruit to a certain extent clinicians. And I think that's the issue for me. And I would say that the decision makers on this need to think about the risks of both scenarios.
Okay, thanks for that, Paul. Neil, you want to come in?
Yeah, Paul's helpfully balanced some of the views there that I have scribbled down on my pad in terms of I fully recognise the point Suzanne and Wendy are making, that when you read the application, you didn't get the same clear view that we've got today from listening to Dr. Mullen, who's talked it through. And clearly, if the application said what Dr. Mullen said, it'd probably be easier for us to work through this. I think that we've also heard, and some of my questions of John about the Save Our Surgery group, that for me the big gap has come in, I guess, some work was done back in December, January to asked for some feedback, and then we stopped at the end of February, and then we got an application in September, and we didn't do all of that normal engagement work in the bit between. And clearly, you know, we've seen from what's come in the presentation from the Save Our Surgery group that people just don't understand what this would mean to them. And I strongly believe that that bit of work in the middle would have made it much easier for us to say yes or no. And I feel that it's hard to actually get to a point. Personally, I know some others may have got to a point in their heads without doing that work, because if we were to make a decision to say yes today and we can't answer a member of the Save Our Surgery group tomorrow with what does this mean to me, then how can we make a decision, is my personal view on it. But I fully follow the logic that I've heard today from Dr. Mullen and William and others, that the saying go away, Danebridge, you can't do this, I don't think is a viable option, because the practice, I think, have been quite clear in the letter from Dr. McGregor Smith from the practice partners. They aren't going to change their mind on this. They've made a clear decision. I'm sure, having given it lots of thought and sleepless nights, that we don't believe it's viable for us as a business to run that surgery. So the idea that we just say, go away and carry on as before, I don't think is an option. But equally, just making a yes, get on with it, close on the 31st of March, equally doesn't feel viable at the moment, because we've got 790 people, or whatever the number John's quoted, who haven't got a clue what it means to them tomorrow if that decision is made.
Thanks for that, Neil. So what I'm hearing from people is, because there's been a different perspective put into the information that we were given in the application, that there's a feeling, if I'm picking this up right, that there should be given more time for more work to be done on what will the primary care offer be for the people in Sandyway before we make a decision in terms of whether it should close the branch surgery or not. Have I got that right? Are people agreeing with me?
No. And that was my view. That doesn't necessarily mean that's anyone else's view.
No, but I'm hearing from Paula that she's got some extra information that wasn't in the business case, and that there has been a lot of information brought forward today that wasn't in the business case. So what are people feeling? Suzanne, did you shook your head then? How do you feel?
Yeah, I don't think we should defer a decision. If the decision is that this isn't financially viable for the business, which is not what the application says, but if that's what we're saying today, that this business is not financially viable over 3 sites, then I think they need to go away and think about some of the actions they put in place to help mitigate those risks about the blood test samples and the prescriptions, and what they're going to do to assist that population. I don't think it's fair to say they're still going to have a service, but you've now got to get 5 or 6 miles to go and get it, or whatever the distance, because the reality is, for some people, that will be an extreme challenge. And I don't think, from the equality side of things, you can't just treat everyone equal. For those that have some disabilities, you do have to do more. So I think, with that hat on, I think we need to look and actually ask ourselves, are we being fair to our patients? And have we been really honest and transparent? Because we've not actually said this is about financial viability. I know we're talking about lone working, but I think that's being overstated about lone working and the risks of that. I'm not convinced from the case presented, and I've heard a lot of arguments about it. That's true. Lots of GPs lone work, lots of people who do goes out on calls, they're still working on their own. They're still at the end of a phone. I'm not sure that that's not being used. And at the same time, the practice has run down that site and reduced the nurse, etc. So I think there's some more. I would like to see a more offer of assistance and solutions from the practice before they actually have anything shut down. So whether that's not saying a no, but that's saying you're going to do it, I would like to see it over quite a long time frame to make sure we get the assurance that it is done. So maybe some caveats that they shut it on the condition they address these things for the patients and the population of that area.
Okay, but it's my understanding that we're here as a committee today, and this is a bit, sort of Paul touched on this. We're here on a primary care, we're on the Primary Care Commissioning Committee. We've been presented with an application, and we basically have to make our decision on that application. We can speculate forever, can't we, that if the practice did this, or if this happened or that happened. What we've been asked to do is to decide on the basis of that application whether or not the surgery should close. And I'm hearing from you that I think we've got a lot of information. I think we've all taken on board that people are going to be disadvantaged if it does close, especially the vulnerable in the community, and we've heard a lot about the transport issues. I'm worried that we're now bringing in an area where we actually don't have control over as a committee. So we could, I don't know if we can say, yes, you can close, but it can't be for 2 years until something else is in place. I don't know. Maybe Neil can advise me on that.
Sorry, Pam, I wasn't suggesting 2 years, but I was suggesting some sort of come back in the next 6 months or something that they have addressed these issues to assist. I'm not saying 2 years.
Sorry, Pam, Chris will be able to describe the process. If the decision was yes, Chris will describe the process of the terms that we can place on the practice in terms of what they would have to do before the actual date. We know it says 31st of March in the application, but we can stipulate things have to be delivered, and if they're not done by the 31st of March, clearly then that date doesn't apply. Chris, do you want to just pick up how that process works?
Yeah, so
Chris.
if, can you hear me? Sorry, I've got problems with my screen, so I can't pull the papers up, but I daren't do anything in case I disappear again and you think I've run off. So I'm just staying as I am, looking at you all. So if the committee agree that the closure can go ahead, what normally happens is, and if Kathy's around, she can jump in if this isn't correct. We would agree a close down plan with the practice, which would answer some of the points that you may want to raise in terms of can you make sure certain things are covered. And only when we're happy with that plan would we agree a date for closure. So what you'd be saying as a panel would, as a committee, would be that you are happy that the site of provision is withdrawn, but until you can't agree a date until all these issues are resolved. What I would say is most of them should be in a closed down plan anyway. So i.e. that you're going to address the issue of where patients go for blood tests, etc., whatever that may be. But to be fair to the practice, they've already articulated some aspects of that are already covered because some things patients have to travel to the other 2 surgeries to cover. So my answer would be it depends what your conditions are. If your conditions are primary care closed down type conditions, that's fine. If there's something, I think Dr. Bowen articulated, it's not to do with primary care, that's not a reasonable ask. So for example, we want to say what you'll do with the building when it's gone, that isn't within our gift. Does that answer the question? They have to do with primary care provision. But we wouldn't agree a date of closure until we were happy that the usual primary care issues had been resolved before they actually closed the door.
Okay, Suzanne, you want
to answer the question? Sorry.
Suzanne, did you want to come back in?
No, it is only with regards to primary care. I fully acknowledge that once they've shut the site, then whatever happens to that building is nothing to do with this committee or whatever. Whether it's to do with CCG is debated. But no, it is purely to do with those things that have been raised and haven't been tackled in the actual application, which I don't think are unreasonable requests.
Okay, Paul, you wanted to come in again.
Yeah, I just wanted to ask Suzanne, please, because I felt we drew Mike into a conversation about the finances. I specifically asked him, how much is it going to cost you to, mitigate against the lone working, against the lack of supervision? He was forced into making a decision, and we then moved on to talking about GPs as independent contractors. But to be fair to the practice, they didn't put that in their application. Their application, as it sits in front of me now, is based on safety of staff and the sustainability of the clinical service. And I feel that I wouldn't want the I feel that we drew Mike into discussing about the ins and outs of having to invest partnership funds and what have you. But that was, of course, we were inquiring as to the mitigating actions against his reasons for closure. Not so he didn't put in his paper, or the practice didn't put in their paper, that we can't afford to run it. They weren't that explicit. They focused more on the safety and the lone working, and we did explore that. So I wouldn't want that to be a potential misgiving that we were giving that. But I also think, yes, you might feel that lone working is over, you know, is over eggs or whatever, Suzanne, in terms of, but that's why I asked William the question of the LMC's position and about the evidence, because again, it's not in the paper, and I think the paper could have been improved with references to evidence about lone working. But as a GP myself, and and more importantly, looking at strategic direction that we're going as the NHS in primary care, lone working and unsupervised working, whether you're looking at training positions, whether you're looking at recruitment, whether you're looking at safety, is that there's a wealth of information out there about the movement against that. And I think the paper could have been improved about that. But I don't think we can purely say, you know, I think it's overrated, or I don't, you know, I think, you know, there's plenty of lone workers, you can sit on your own and work from home. We're talking about the provision of good standard care, and I think that case was put today.
Okay. Does anybody else on the committee want to come in on anything? Because if not, I'm going to move to the voting members of the committee and ask them what they think. Okay, so I'm going to move, I think I'll go through, sorry, Wendy, I'm going to put you on the spot first. Wendy, what do you think in terms of the decision? Do we need more information, or do you feel that you can make a decision?
I think that what we've had input now has been make a decision on the case as presented. And as presented, I think several people here today have actually said, not quite there. So I feel that this is a very important decision, and it impacts on a lot of people's lives. We have had additional information given to us during this meeting, but those were opinions of obviously Dr. Mullen himself. I really do think I would like to have seen some backup information, a good impact assessment on the patients, on what will happen later. And I would think that to make sure that we would make the correct decision, I would like further information. I think that at the moment, given the amount of information we had in the case that was sent to us, it was insufficient to make that decision.
Okay. Suzanne?
Yeah, I agree largely with Wendy in terms of that. I think for me, the main issue is not having further information about the viability and the impact also on the practice if it doesn't close. That isn't clear. I know it talks about the benefits, but it's already been pulled out by Paul. We didn't have a detail of what those benefits really were going to be. I would like to see a bit more information before I feel assured that it really is the right decision for the practice as well, and happy that that genuinely needs to be done. But also, as I said before, I'd like some more assurance that the populations of the local practice, now that's going to be maybe closed, whatever happens, get some of the answers to those things where it's important to have them for the blood tests, etc., and how they're going to be handled. So no, I want to support based on the current position.
Okay, and I'm going to put Andrew on the spot. Andrew.
Hi. I personally felt that, you know, I think from the evidence that's been presented that I probably could make a decision today.
Okay, so there's nothing that you think's missing. Okay, I'm going to come back.
You know, I don't feel like it, you know, so think we've used the term sort of business case, and I think that the practice did fulfil their application, what they need to fill in to move forward to a branch closure. But I think they did fulfil their part of what they needed to do to move this forward. So I think if we're now asking for something else, then that's a slightly different ask to for a case for change.
Okay, Paula.
Thanks, Pam. For me, it'd be about making a decision about sustainability of clinical services, either for keeping in the practice or actually for supporting the practice across its other 2 sites. And that's the criticality of the point here, really, is the sustainability of clinical services. Because if they're not sustainable in any of the sites, then this is rather a futile discussion in terms of the discussion about the branch surgery. And I do think that the application does talk about the sustainability of clinical services. I think we've had additional information that actually broadens what sustainability means actually today. So I think sustainability is in the application, but I think we've had some broader aspects around sustainability today. One of the things that we haven't spent much time talking about was actually the push back from the Overview and Scrutiny Committee about actually the length of time taken to discuss and engage in debate. I think Neil made a really helpful point about that gap during which time, clearly you can hear that, the commitment from the practice around, wanting to engage with their population, and I think that gap has driven some of the concerns really that are making it more challenging for people to land a decision. It's out with the way the practice would normally engage with their population. You can hear that in terms of, Mike's pride when he talks about his practice and the, the commitment to their population. So sustainability information, I think, is in the application. We've heard a wider use of how we describe sustainability today in terms of thinking about financial impact as well as clinical services. But one thing that we haven't thought about was really, the Overview and Scrutiny Committee did actually say to us, has been enough time and thought and energy given to understanding the mitigations? And I think a number of people today are saying we can hear mitigations for virtual appointments, although we recognise that that has an impact on some of the population. We can hear some mitigations for prescriptions, but we're not hearing much in terms of mitigations around transport and samples, a number of other aspects. I also take the point that a lot of that may not be within our gift, but also I think if you listen to the Save Our Practice in terms of Save Our Surgery, you hear such a strength of passion from them about wanting to engage and be solution focused. I can't help but think that we are losing some value there in not spending a little bit of time on that we would have captured through the focus groups. You can hear that from Mike today, a very approach to wanting to look for some mitigations and solutions, and not necessarily just for keeping the branch surgery open. For understanding if the branch surgery closes, what are some of the other mitigations that they could work alongside as well.
So are you asking for a deferment for more work? Is that what you're saying?
What I'm saying is I don't think we've listened to, we've not really discussed the point made by the OSC about actually. So we've talked about the case in the practice, we've talked about the case from Mike, but actually Matthew's given us some information about the engagement process. But there is, there are some 4 very clear points being made by the OSC actually about whether this process has been of engagement, and I'm not sure that we've answered that question today in terms of making and landing our decision. We could make a decision, and I think the OSC paper seems to be saying that they're not convinced that we would have been through adequate processes in order to make that decision. And I think there's been rather light on that in our discussion, our debate over the last 2 hours.
Matthew, have you got a view on that before I go to Neil?
I suppose the view on what is from a question. So we have to listen to what scrutiny says, but we don't have to observe what scrutiny said. I don't think anything they raised is unreasonable. Again, it is perspective. I think they have echoed some of the debate we've had just now in terms of do we need to look at this in a wider sort of sense in terms of the impact on the community. But I completely understand where Paul and others are coming at in terms of, is that the role of the primary care committee? It is yes and no. I picked up your point before, I think the other point before about going out to further engagement, which was Neil's point. So if you are going out to further engagement, the question is it us as a CCG talking about a bigger picture, or are we asking the practice to go out and engage further and clearly more articulate their reasons? However, is the end result still the same in their eyes? So I'm not entirely sure whether an extended period of engagement would necessarily get you to a different conclusion. I think the other aspect to it is, yes, we've got the application in front of us, but the purpose of this is that you've had lots of more supplementary evidence for you to form your consideration. And if you feel that you've had enough supplementary information from the questions asked and the other reports, and you feel that you can make a decision whether to accept or reject, and that is the decision, is it accept or reject the application, then you should look to do so. If you don't feel like you've had enough information to accept or reject, then you do need to come to a conclusion around deferment. But deferment does mean you are expecting to see something come back to help you have a much clearer understanding of the accept or reject rationale. Does that help, Pam?
Yes, thanks very much, Matthew. Neil, I'm conscious I've left you to the end. What's your view?
I'll try not to repeat what I said earlier. No, my starting view is this isn't going to go away. If we say no, it doesn't, whilst it may appear a small victory for the local population in the short term, we know it will cause problems for the wider Dainbridge population in the medium term, because of all the points we've discussed today. So there's two approaches, and I must admit I keep bouncing between the two. The first one is we say yes, but we have a number of caveats which we've already touched on in terms of before you can actually close the doors, you need to work with the local population to address these points and make sure there is a solution for these points, because I do feel like there isn't a firm plan on many of the things, even some of the things like repeat prescribing and some of those things that were touched on earlier didn't feel a totally firmed up plan, and understandably that's leaving questions unanswered. Or the second option is that point that we raise a number of areas of query and say before we can fully consider, we need to know what your plans are to address these. And you may say that they're actually the same things I'm saying. It's just whether we're saying yes now or in all likelihood we're saying yes in 3 months' time. So that's why I keep bouncing between whether I'm saying yes with caveats or no, but when you come back having done these things, we'll probably... The only other final point that I think John made earlier, which I know the answer to, but I know the answer I think I know the answer to, but purely based on using common sense, is the point that we've got two surgeries very close together. We've got one small satellite surgery that's 5 and a bit miles away, and we're closing the one 5 and a bit miles away. In an ideal world, I guess if you were putting a pin in a map and starting from fresh, you would close one of the two surgeries close together. So, I think we all know the reason why, in terms of the quality of the building, etc., the size of the building. Well, that I don't think has ever been articulated anywhere. And I'd suggest if the answer is going away without making a decision rather than saying yes with caveats, that I would want that answering, even though I'm pretty damn sure I know the answer.
Okay, so having listened to people, I mean, Wendy, I know Wendy's had to leave us, unfortunately. Wendy has said she wants more information. Suzanne says she wants more information. Neil is saying he would like some questions answered, but recognises that it may well not change what his decision was. For me as a chair, I think we've either got to say we defer this decision and we need to be clear about what information we want to come back to us, because we're going to have this debate again? Or are we in a position to say yes or no? And from what I'm hearing from you, we are not in a position to say yes or no. Do members of the committee agree with that? I know Andrew doesn't, but do people agree with that view? That we should defer the decision? I'm going to go through again.
Yeah, I can tell from my point, I'm probably saying the same thing with two options, so I'm comfortable with that view. We need to be very clear on the information we want, though. As I say, my main thing that you've heard is, I think there's a residents group that have to be actively involved if we are going to do that, in terms of here are the key questions, and it becomes less about the business logic and it's more about the solution. That's the bit that I've got a gap with, really. I can fill the gaps on some of the business case arguments. Have we got a real plan in place in terms of how we will mitigate the risks for that 3,500 people in terms of their future service model? And I don't feel that I've necessarily seen that.
Okay. I think we need to work out whether or not we need to defer or not. I need to ask everybody again. Neil, so you're saying we should defer. Wendy's saying we should defer. Suzanne's saying we should defer. Paula, are you saying otherwise?
I'm saying I've got enough information to make a decision in terms of sustainability, in terms of the clinical model. I don't think we're going to hear anything that will change that. I think we've seen it in the application, and Mike's provided more information on that. I am listening to colleagues' view though about actually some wider information that may make expand on some of the mitigations, and I think there is a strong case for expanding on some of the mitigations. I don't think the issue around sustainability will change in terms of the real honesty that we've had today.
Okay.
Can I just come
Andrew?
back in, Pam? Pam, can I just come back in? It's Neil here. Just to say, Paula just said, the mitigations I'm talking about are all primary care based. It's about the primary care model, very, some very specific. And Matt Mullen read most of them out earlier, but I didn't feel they were, they were concrete in what the plan was.
Yeah, okay. So we're needing, what you're asking me for is some more, we want some more information to make a decision on the mitigations in terms of the risks of whichever way the decision goes. Is that what you're all saying?
What I'm hearing is, I think we're going to have the same, my fear is if we defer, we have the same conversation next time. I mean, in terms of the application, I think it's been poor. There's been a lot of stuff that's been discussed today. I can't say I'm enamoured with the way the application's been done, but I hear what's being said from colleagues, and I acknowledge, I'm not a clinician. On the other hand, if I was looking at a risk, I would be happy to say, okay, we vote today, but with, as Neil and Paula have said, the mitigations and the assurance are then part of what Chris has referred to, a closed down plan, whatever that is. We make sure that we have those in place to protect those people that need protecting, so the vulnerable people with those particular potential issues over bloods and pharmacies, etc.
Okay, so what you're saying, Suzanne, is we should still make a decision today, but with caveats.
Yeah.
Okay.
Yeah.
And that, I think, is what Paula was saying as well. Andrew, you felt able to make a decision today. I know Wendy has expressed to you that she feels unable to make a decision. She would like to take some further information, but I think probably I was hoping that we would have a consensus view here. So I'm going to ask people whether they think the surgery should close or not.
Pam, can I just come in here, Pam?
Yeah, sure, Chris.
Because my chat box isn't showing up. Just before you do that, I just wanted to pick up something that Suzanne's just said. Again, I'm not a voting member, but it's just from my perspective, from a contracting perspective, I think I would feel more comfortable in deferring this decision and making it with more information than I would saying yes, but here's some conditions that you must fulfil, because I don't think that gives the power back to the committee to look at it again. I think that gives something to an officer to sort out outside of the meeting. Does that help?
Yes, it does help. So what you're telling me is we've got to defer.
No, I'm saying that if this is a really important decision, and I don't think anybody should be apologising for needing more time and more information to make the right decision. I think saying we'll say yes, but here's a list of things that we're not quite clear what they are at this point in time to go away and do after you've made the decision doesn't feel, I'm not entirely comfortable with. I just would put that out there. I would prefer the deferment with more information articulated, perhaps taking into account what Dr. Mullins said in a more written form. But you don't have to agree with me. I'm just trying to say it's putting the power back into the committee to say, right, okay, we went away, these 12 things have been addressed, rather than saying, we're saying yes, but go away, officers, and make sure these are all addressed when they close. I feel that power should lie with the committee, if that helps at all.
No, I think you're right, Chris, and you're right to point that out. So, and I thank you for that, because I too would personally rather defer than make a decision in haste and afterwards think. Because there's been a lot of information that's been given us this afternoon that wasn't in that business case, and I just think I would like some time to think about what's happened today and what further information, or even to just process that information, to be honest. So I would prefer that we defer to the decision. That's my preference, but it's up to my colleague voting members to whether or not they agree that or not. So can I ask whether or not people will agree to a deferment? I know Wendy will. Neil?
Yes, I will. I'm listening to what Chris is saying. As I say, it's already recorded my view that we'll probably end up at the same place. But I take Chris's point that there's something around keeping control over it rather than making a decision now and then regretting making that decision because we're struggling to ensure that our concerns have been addressed.
Okay. Andrew, are you all right with that?
Yeah, that's fine.
Okay. Suzanne?
Yeah, that's fine.
Okay, and Paula?
Yeah, I support that as a proposal. I think it was really helpful to hear Chris make that point, actually. Point well made, thank you.
Okay, so who haven't I asked? Wendy, but she's not here. I'm sure Wendy would agree to a deferment. So basically, there are 5 of us still here, and all 5 of us have agreed that we're going to defer that decision. What are we going to require, though, for to happen between now and the next time we meet? Neil, can I ask you again?
Yeah, so there were a list of concerns that I say Dr. Mullen went through some of them earlier in terms of how local residents would be able to access services. Now, I'm not talking about public transport here, to be totally clear. I don't believe that that's in the gift of anyone, either the practice or the NHS, to resolve issues of public transport. But there were some things which had been rightly flagged through the consultation around things like meds monitoring arrangements, repeat prescribing, samples, which as it stands today, I think there's a view on some that we can do something there, we can't do anything there. I think we need really firm proposals in terms of what they are. I think they should be developed through a process of engagement in terms of some kind of focus group approach, which I'm hearing has been advocated, but recognising that doesn't mean, no disrespect, John, but that doesn't mean that we just are able to give everything that the local community asks for. It's more that it's a jointly developed understanding of what the things that are realistic and not realistic are. And then I do think, as I say, my final point is that I do think was missing was the written confirmation around why Sandyway. As I say, I can guess why Sandyway, but it's not clearly specified why Sandyway, not Kingsmead. I think that should be confirmed in writing, but as I say, I could write it myself, I'm sure.
Okay, thanks for that, Neil. Paula, is there anything else you want to be brought back to the table when we meet again?
No, it was the points really that that Neil's listed there. Really, when I was listening to Mike going through his presentation, there are a number of those that I think are within our gift to give consideration to, and I think they're the focus areas for me. And some of the things that I've written, and we won't be able to mitigate some of them completely. You know, we've already had some challenge about people not always being able to use digital platforms, but I would be more comfortable if we look to address some mitigations, accepting that they won't work for everybody. I think that's a very fair point in terms of equality and impact that needs pause and thought to be given to in terms of impact. But I think there is something about focusing on some of those that were listed in John's presentation.
I know. Yeah, okay. Andrew, have you got anything you want to add? No. Suzanne?
I think Neil probably picked up on the areas I was looking at, and I think there is something about impact, which Paul has just mentioned. I think the why Sandyway then may pick up some of the strategic stuff that we perhaps haven't had, and just confirmation. I appreciate Mike's given his views on some of those, but I would perhaps like something from Fiona herself on that, on the strategy on why it's Sandyway and why they've chosen to do that.
Okay. Mike, are you happy to work with, you'd obviously need to work again with John in terms of going through all these things. Is that okay with you?
Yeah, absolutely. I think if the committee understand the arguments that have been put forward, and I think speaking on behalf of the practice as I am today, certainly I think we would be very keen to get to a solution, to find some mitigation to many of the points which have been raised, and get something firmer, something in writing back to the committee, so that a decision can be made based on what we're asking for and how we're mitigating the fallout from the closure of the practice. Yeah.
Okay, thank you for that, Mike. That's really useful. So the final thing then is, if we're deferring, how long are we going to defer for? I know that the next committee is not until the 4th of February, but I'm conscious of the fact that it's now mid-November. We're in lockdown, we've got COVID and winter, so is that long enough, the 4th of February, for it to come back? Or is it too long? Are people okay for the 4th of February?
I wouldn't like to see it extend beyond that, Pam. That's Paula.
Yeah.
I think there is something about moving forward assertively and you know, notwithstanding the challenges that you've just listed, Pam, and being respectful of that, but I think some of that would be about, we need to check that out with the practice, and also as well with some of the population about what's reasonable. But I think when you start to move past February, you know, it's quite uncomfortable to me. These are important decisions.
It's very early February, it's the 4th. It was the first date that we could actually find for the committee on a Thursday, because obviously our GP colleagues have Thursday as their CCG day. So that was the 4th of February will be the latest. There is, if it's done before, there's no reason why we can't convene an extraordinary primary care commissioning committee, but sometimes that's quite difficult because we're quite a big group to get us together. But certainly I would see that at the beginning, if you think the committee's on the 4th of February, we're going to need the papers at least a couple of weeks before that anyway. So you're talking mid-January really for the work to be finished.
Sorry, could I just quickly come in? Can we just really be mindful that we don't end up with the repeat of the Christmas scenario from last year? that actually if there is meaningful conversation to be had with residents as part of this, if that's what we're saying, that we're not going to end up doing exactly what ended up happening with the timing last time round.
Yeah, that's right, but we've got 2 months, Louise, really, realistically, and some before the 4th of February. So we should be all right, because we're early November. We've got the whole of November, really. We've got half of December. We've got the whole of January. So I think we've got 2.5 months. I think that should be enough. Are people okay with that?
Pam,
Yeah.
can I just say a word? I guess from my perspective, we at the practice obviously would, still the sentiment of momentum and wanting to move on and make a decision. And I think 4th of February, we certainly will make every effort. My only concern is if we are in the middle of a pandemic and we've just gone into another lockdown, and who knows what's happening in terms of the volume of work and demand which is heading the way of primary care. So I think if there are significant changes in that direction, we would seek to postpone that date. But certainly I'll have a chat with my practice manager after the meeting, and I think that is we would certainly aspire to get all that work done by mid-January and get the papers and the paperwork to you, unless there are some big changes in the workload.
I hear what you're saying, Mike, and I'm fine with that. I take Louise's point as well, in terms of the fact that if because of whatever the situation is that we find ourselves in, it becomes impossible for you to do some of this work, then yeah, we need to look at that. If that's the case, then that's fine, and I'm quite happy with that. What I don't want is for it to linger on and linger on. So yeah, I think I'm fine to say I'd like it to come back to the 4th of February committee, but if there are issues in terms of that, then surely let us know and we can take a view on that and postpone it. Has anybody else got anything else they want to say? No. So, well, I shall pull things together then at the end. So the committee's agreed to a deferment. It's agreed that some work needs to be done, and we've got a list of those areas that need to be worked on between the practice and between the public or its patients. So our next steps will be for something to come back to the committee on the 4th of February, and it's in the afternoon, is that meeting. So it just really remains for me to say thank you very much.
Pam, it's Neil here. Could I just add
Hi,
another?
Neil.
Clearly, we need to write to the practice confirming exactly what it is we're asking them to do. So as a matter of urgency, we'll work to get a letter to the practice to do that.
Yes, thank you, Neil, for reminding me. Matthew, is there anything else you want to say in terms of governance?
I'll probably need to have a lie down and think about it, I'll be honest. There's an element, well, I'll start with the first thing. Just to give that offer to Mike and Amanda, really, obviously our comms team can support, but again, we'll support in a way that doesn't compromise the independence and integrity of the CCG. But we do recognise absolutely you're entering into a busy period, or a busier period, because you're always busy. Again, it's still within the gift, absolutely, of primary care to have deferred it, and you are still the decision-making body. So, coming back is still the right thing. I'll just really echo what Neil said. Is I think as a committee, you need to be really clear on what it is you're asking the practice, and any of us like ourselves, what it is that you need. By deferring, and you do need to be mindful of this, by deferring, you are still accepting there's a possibility that the application could be accepted. So you've equally said we can't see an automatic rejection as well. So you do need to appreciate that. I will need to give a little bit more thought now as to how we engage further with scrutiny on this. And I don't have an answer today on that one, but we do need to officially respond within the 28 days. But my last point really is scrutiny is a partner in this, so I'm sure they'll be supportive in helping to enhance any further information that will come to the Primary Care Committee. The same is true, of course, of Health Watch. Sorry, Louise, I didn't mean not to include Health Watch in that.
Okay, I think it might be helpful, Neil, if the letter is produced, that it's circulated to the members of the committee, just the voting members of the committee, just so as we can make sure that we've got everything in before it's sent out, if that's okay. Okay, anybody else got anything else to say? No. The fireworks have started outside my house already. So it just leaves me to say thank you very much for all your attention today. It's been a long meeting, but I need to recognise also that there's been a tremendous amount of work done, not only by the Save Our Surgery group, but also by staff within the clinical commissioning group to even bring these papers here. I don't underestimate the amount of work and the amount of time that people have taken to do that. So thank you to everybody. And that just leaves me to say, I hope you have a nice evening, and thank you all for attending. Thank you very much.
Thank you, Pam.
Thank you.